Hello, 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 hello. Oh my god. This was switched off. Now you'll get it. Now let's see that. Great.
Hello, hello, check. Hello, check. Hello, hello, hello. साउंड आ गया होगा हेलो हेलो चेक हेलो 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 चेक हेलो 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 चेक हेलो 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 चेक सिग्नल लेवल कम अच्छी दरकार अच्छी ना बाजिबनी ना हेलो कहीं टानुनी टानुची माइक्रोफोन नहीं लगा माइक्रोफोन प्रशांत प्रशांत
ये फिक्स कर दीजिएगा ताकि फिर वहाँ लूज ना होता रहे. चलियो. हेलो हेलो या डाल देते चलेगा. पहन सकते हो उसके ऊपर ना. ओके. ये साउंड ऑफ कर दें क्या? यही साउंड जाएगा ना. ये साउंड जाएगा ना. ठीक है. वहाँ से ऑफ कर दें.
कैमरा कैमरा कैमरा
ये मेरा साउंड ऑफ कर देंगे अभी, कहाँ से ऑफ होता है?
चर्चार कोठी हला कोडा एइटा एइटा भी सेही बा
हेलो 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 हेलो
ଶୁଣ ସବୁ ଆମର 1 ନମ୍ବର କାମ କରିବ 4 ନମ୍ବର ସେମାନେ ଆସୁ ପଛେ ଟାଣୁ ପଛେ
हेलो हेलो
ଭଲ ଶୁଣୁଛି ଏଇଟା ସେଇଟା everything is there, sir.
सर
स्लाइड टा
काट दवा जल्दी काट दवा
ना ना सुबिया दरकार है फिर असुविधा
କରିଥିଲେ ସାର୍ ପିଆଇପି କିଛି ଦେଖୁ ବହୁତ ଛୋଟ ଥିଲା ଦେଖି ପାଉନଥିଲା
So we need not be seen, no?
ଟିକେ ବ୍ୟସ୍ତ ଅଛି ମୋତେ କର 7ଟା ପରେ କାହାକୁ କାହା କରୁଛ
Yes, we are actually on your team. You can start.
କୋଉଠି ଗୋଟେ ଭଲ ବ୍ୟାକଗ୍ରାଉଣ୍ଡରେ ଷ୍ଟାର୍ଟ କରିବା କୋଉଠି ଦେଖାଯାଉଛି ଆସୁନାହାନ୍ତି ଆସ ଆସ ତୁଲେ ନାଇଁ ଆସ ହଁ କାଟିଦେବି
ଆଉ ଟିକେ ସେଟ୍ ବ୍ୟାକ୍
ଆଜ୍ଞା ଅନ୍ଟା ପୁରା ଅନ୍ଟା
ଅନ୍ ଅଛି
स्टार्ट करें आरंभ करेंगे लैपटॉप रेडी राजू हाँ कल हाँ स्टार्ट Basu. Good afternoon, everybody. Welcome to this BOE USI webcast session. We are very proud to host this event of BOE USI. This is the first event of the year, and this is on female urethral stricture. As we all know, it's a neglected entity all over the world, and nobody knows what is the reason, how to treat it, how to diagnose it, and how to follow up. So basic problem is the urethral stricture and the suffering of the patient. We are trying to analyze the patient's outcome by doing this surgery. We will also put this on the website, the post of follow-up and how the patients are doing with all the uroflowmetry reports later on. To start with, we are proud enough to have two of our guest faculties. Let me introduce you to them. Before that, let me tell you, myself, Dr. Debadarshi Rath. I am here as an associate professor in IMS SUM Hospital, Bhubaneswar. It's a private medical college and one of the premier medical college, private medical college of the state, catering highest number of the patients apart from the government medical college. We have chosen this topic and invited our guest. First of all, on my right, Dr. Sanjay Pandey from Dhirubhai Ambani Kokilaben Hospital, Mumbai, and Dr. Arvind Panda, he is the professor of urology in CMC Vellore. To my left, my boss, Dr. Suren Kumar Das, he is a professor and head of the department of urology in IMS SUM Hospital, and to the left, Dr. Prashant Nayak, he is from All India Institute Medical Science, Bhubaneswar. This is the best medical college of AIMS apart from Delhi. So we have got all the faculties and we wish the patient suffering will go down and after the surgery. Let's start this presentation. Over to Dr. Arvind Panda.
Mine is the other one. Please make it F7. What's up?
He will speak now.
I'll just go through very quickly the surgical anatomy of the female urethra. The perineum has two triangles, the urogenital and the anal, and there is the pelvic diaphragm which separates the pelvic cavity from the perineum. This is known to all of us. The female urethra and the distal vaginal wall and the erectile tissue are in the urogenital triangle, and they are not flush, but they sort of project from the bony landmarks for about 3 to 6 centimeters. And what we have to understand here is that though the female urethra is different from the male, there are certain similarities. It is embedded in the anterior vaginal wall, but it is surrounded by the erectile tissue in all directions except posteriorly, except where it relates to the vaginal wall. In this case, it is slightly different from the male. In the male, you find the erectile tissue only dorsally. Here you find it not only dorsally, but also on the lateral aspects. The urethra itself is about 4 centimeters. Though its diameter is normally around 6 mm, it can easily be dilated to more than 1 centimeter. It extends from the neck of the bladder to the external meatus, as we know, and is oriented almost vertically in the standing patients. It has a transitional epithelium proximal and a pseudostratified epithelium distal, and it becomes almost stratified when it approaches the skin. It has submucosa and mucosa, and there are two muscular layers, the inner longitudinal and the outer semicircular layers. These layers are also important in, to some extent, for the continence of the patient. So this is the layers of the urethra. This is a cross-sectional view, and its blood supply. The female continence mechanism. No discussion is actually complete on the female urethra without discussion the continence mechanism. The female urethra plus the rings of the detrusor with surrounding endopelvic fascia and the muscle, all of are responsible for the continence in the female patient. And you have this inner sphincter, which is basically, there are two components of it. This is the bladder neck, and there are two components. One is a trigonal ring, which comes from the trigone and encircles the urethral lumen. This is the most important part. And there are two loops of the detrusor. One which opens posteriorly, called the loop of His, and the second which goes under the trigone, opening anteriorly. Both of these allow the urethra to go between them, and when they contract, there is continence at the bladder neck. Also, the layers of the urethra, the vascular spongy produces the mucosal seal, and there is this compression from the middle muscular coat, and there is some resting urethral close-up pressure which this muscular coat gives me, and plus there is the outer seromuscular layer which augments this close-up pressure. All of them are responsible for continence. The submucosal plexus and the epithelium of the urethra are extremely sensitive to estrogen. So hormone replacement therapy in the postmenopausal woman improves blood flow to these layers and may in some extent aid continence. And then there is the external sphincter, which is in the deep compartment. There are three skeletal muscles which are actually a part of the external sphincter. One is the sphincter urethrae, second is the compressor urethrae, and the third is the uretrovaginalis. All these components act as one unit. They contract voluntarily and they prevent incontinence. The last two, that is the compressor urethrae and the uretrovaginalis, also compress the vagina. The resting tongue contributes to the pressure inside the urethral lumen, and this external sphincter can be damaged from childbirth injuries and surgery. And the more important thing is the endopelvic fossa. In an nulliparous standing woman, if you look at the diagram here, in a nulliparous standing woman, the bladder, the proximal 2/3 of the vagina and the rectum lie and oriented almost vertically. So some of the organs are almost horizontal, and the distal part and the urethra are almost vertical. This relationship is quite important for continence, and it's maintained by the endopelvic fossa. The endopelvic fossa is microscopically a three-dimensional meshwork of collagen. There is this pubocervical fossa which comes from the pubis, and it's sort of and fills with the vaginal skin, providing a sort of hammock or sling for the urethra and the bladder. and increased abdominal pressure compresses the lower urinary tract against the pubocervical fossa, promoting continence, so-called the urethrovesical junction trapping. And there are of course the muscles of the pelvic floor, the levator muscles, the pubococcygeus and the iliococcygeus. And these muscles are in a constant state of contraction and they cause efficient positioning of the urethrovesical junction. Again, very important for continence. The female continence complex, therefore, has multiple structures. One is, of course, the loop of the specialized detrusor muscle, the urethra resting on a hammock of the pubocervical fossa, the external sphincter mechanism, and the submucosal plexus. And incontinence becomes clinically apparent only with multiple failures of these systems. Of course, this is about the vascular supply. The proximal urethra is the infravesical artery, the middle urethra is the uterine artery and infravesical artery, and the distal by the interpudendal. We know all this. I'll just go to the next slide. This is a diagram which shows all the structures. You can see the trigonal ring and the pubovesical fossa and the circular smooth which surrounds the urethra and the urogenital diaphragm here. Now, what I will be showing in my surgery is a non-ischemic continence preserving dorsal inlay buccal mucosal graft urethroplasty in females. And in this, basically, the most important point is that there is no dissection that is carried out around the urethra or above the urethra. Initially, a guide wire is placed in the urethra and an incision is made at the 12 o'clock position from inside, as you can see from inside, as you can see in this these pictures, and this incision is deepened in layers, and this is separated. The walls of the urethra are separated laterally. A speculum is inserted, and opening this speculum gives excellent view of the inside urethra and the proximal neck. The point to note is during this incision, one has to do multiple episodes of cystoscopy because there are really no landmarks inside the bladder. Like in the male, you get there are no landmarks inside this urethra which will actually tell you how close or how far you are from the bladder neck. So we have to do cystoscopy each time when we extend the incision proximally, and then sutures are taken and a graft is slid inside and then sutured to these edges. So this is how it's done. This is the incision, and finally a graft is taken and is sutured, and that's the final picture. Thank you so much. I just wanted to finally tell you the advantages of this technique. It avoids circumferential dissection of the urethra, will result in less ischemia, and there is preservation of the nerve supply, of the urethra and of the clitoris, and there is careful complete incision of the strictured segment with the cystoscopic conformation which prevents irrelevant injury to the neck and incontinence. The dissection of the urethral edges and the subsequent lateral spreading ensures that there is adequate lumen. The highly vascular base ensures almost 100% take of the buccal mucosal graft, and the fixation of the sides to the lateral edge may aid continence. And compared to ventral placement, there is no chance here of urethral fistula, and any subsequent incontinence procedure, if required, like a sling procedures, can be undertaken ventrally. That area is still virgin. Thank you so much.
Thank you, Dr. Arvind, for a nice deliberation. Actually, this is the innovation. He has already taken it up as a challenge for female stricture. So it's a dorsal, but it's inlay. So the next, this next slides will be from Dr. Sanjay Pandey. Over to Dr. Pandey.
Good afternoon, everybody. It's so nice to be back in Bhubaneswar, the city of 1,000 temples, back home to Odisha. Thank you so much, BOE. Thank you so much, Debadarshi and team back at SUM, having invited us to come out. It's a proud privilege to be operating with Arvind and colleagues across the country. Thank you so much for taking up this subject in such a big way. Female urethra, the 4 centimeter challenge. We heard Arvind speak in details about what are we dealing with. We're dealing with the challenge of the complexity of this structure being embraced by a horseshoe-shaped sphincter, the coaptive mechanisms. It shares its walls with the vagina ventrally or volary and the clitoris dorsally. Therefore, the tissues are in so close unison with each other. The inner lining moves from the transitional epithelium to pseudostratified to stratified squamous epithelium. And we're looking forward to the disease female urethral stricture, which at some point of time was always considered rare, amounts to possibly in larger series 4 to 14% of female bladder outflow obstruction. The whole gamut is about what could be the cause of female strictures. We know trauma, the road traffic accidents, the pelvic traumas. Traumatic is a large subset of occlusive strictures, but there's also a large subset of patients who undergo iatrogenic stricture formation, possibly because of repair of female urethral diverticula by me or you, possibly fistula repair or incontinence treatment being done in the yesteryears and even today by the techniques that are changing and evolving. So iatrogenic happens to be a large subset of issue. Why? Because inappropriate treatment of lower urinary tract symptoms in women with urethral dilatation has emerged as quite a leading cause at this point in time. I personally feel a lot of women at that age group in their 30s to 70s have undergone treatment of LUTs medically and by a urethral dilatation inappropriately, either by under local anesthesia or under general anesthesia, either too much stretch or possibly attempting to treat them, giving them the best of care under the circumstances with borderline flows, and they may have actually been landing into this kind of a situation. So female urethral strictures, we as urologists deal with female urethra more than our colleagues in gynecology and people who deal with perineum. I think we need to take up this onus of female urethral suffering. There are presentations which women present with. If I look at one of the series where 26 patients who were treated for urethral strictures by urethroplasty, I look at the kind of symptoms they presented with. The overall basic symptom lying in males is poor flow. Recurrent urinary tract infection is another ominous kind of a gentle presentation where somebody has a poor flow adjusted very well in the background and possibly continues to have recurrent UTIs, treated urine cultures, symptoms, unfortunately continues to have recurrent UTIs. And then you and I possibly diagnose that this patient is a case of stricture urethra which has been missed out. Urethral pain, because the whole movement of coaptation, urethral mobility, activity during the whole change is all about that. Hematuria, overactive bladder because of occlusion and stress urinary incontinence. So female urethral presentation of stricture could be of variable ways and therefore the complexity of its presentation. We unfortunately don't have any protocols and guidelines across the world where we could have some kind of a algorithmic approach to this unforgiving tube, which once injured, once traumatized, once diseased, undergoes the process of the change, which is probably culminating into a more of a pipe stem urethra in the end, in those situations where they undergo dilatation for decades together. Now at this point in time, there are improving schools of expertise and awareness across the world, hugely related to the lot of innovations and decision making on table by authorities. And you see Arvind actually coming up with a novel technique that we're going to show you today. Female urethroplasty today therefore is a topic of increasing attention with multiple surgical approaches by grafts, by flaps, locally or from distance. The major technique that we talk about today is a buccal mucosal graft urethroplasty, which could be a ventral onlay into the 4 centimeter tube, which could be a dorsal onlay, or which could be an inlay or an onlay technique as governed by the techniques. Now, these are all transvaginal exposures on a ventral onlay, midline incision from the matus 6 o'clock till healthy margins are reached beyond the stricture. Anterovaginal wall is mobilized off the urethra with careful periurethral dissection. Approximately 1 to 1.5 centimeter wide mucosa, good enough length for us to give a good matus in the end, which is a broad one, is what would be giving an inlay of this technique. So there have been series attempted across the world. The reconstructive urology in the Gold Journal talks about a ventral inlay labia minora graft urethroplasty for management of female urethral strictures. It shows quite a robust follow-up of approximately 2 years in a 95-minute surgery that they continue to do. If I just go back to the dorsal onlay technique that we will show you largely today, which is a robust technique because of the advantage of strong mechanical support and local vascularization by collateral cavernous tissue holding it, and therefore minimal circulations. It's a more physiological repair compared to ventral onlay because the flow is directed more away from the vagina and the throw is better for the patient. A reverse U incision, parametal 12 o'clock incision, dissection along the urethral wall and collateral cavernous tissue preserved by a careful dissection. Sometimes we actually use saline to bring about that defect. Therefore, placement of buccal mucosa in the dorsal defect, it could be an inlay from inside the urethra, what Arvind will show you today. It could be from outside, as I will show you today. And these are two techniques which actually have stood test of time. European Association of Urology last year published the surgery in motion, where there was a lateral based anterior vaginal wall flap in treatment of female urethral stricture, more for a completely rigid urethra, a long segment stricture going all the way close to the level of close to bladder neck, where we probably look at a lateral based, I remember we do the Orandes technique where we do a lateral based flap, we turn it around and bring it into the urethra. Therefore the luminal surface is again the vaginal wall, and we mobilize the lateral vaginal wall from where the defect has been created and repair this. This from Carlo Lopez is a technique which has actually been demonstrated. We prefer to give it for elderly women, women who probably have got a semi-rigid or rigid urethra, and this technique has been taken up by few centers in Europe. The vaginal flap urethroplasty is more of an advancement flap urethroplasty. Today morning when I was discussing with Professor Panda doing the cystoscopy of all the cases, we looked at, this is one of those techniques where we, akin to a Blandy technique that we do, described by Maguire in that era. It's more of a retrusive measures that you would give, would leave the stream little downward, probably hitting the vaginal wall, and may not be the best of it, but again in that elderly woman who has got more of a distal or a metal kind of a stenosis, good enough to just give you a Blandy kind of a technique. There is this important vestibular flap urethroplasty in women with recurrent distal mural pathology. Again, middle-aged elderly woman, somewhere where you can have the distal urethra only to be repaired around, you could actually bring about a vestibular flap urethroplasty from one side and apply it around. So the techniques are now coming up. Series have been presented across the world. It's time female urethral strictures which are refractory kind, which are beyond mucosal, which have the spongiosal involvement, and where dilatation could only be a double-edged sword, giving them some relief initially and thereafter give them the trauma which happens every month and every year. And the ladies who are undergoing surgeries today have undergone dilatation from at least 6 months to 10 years down the line, when we talked in the morning on cystoscopy. That's a contemporary series presented only last year in World Journal of Urology, and it also talks about the etiology and the presenting symptoms around. Overall, the common presentation we see in India is like changes at the introitus, changes at the meatus and distal urethra. Something where we need to look at, work up them. They are middle-aged to elderly women. Some of these women actually would require urodynamics for a complete workup before we would take up a challenge as big as this. I'd like to conclude because we're starting the first case. Urethral stricture is present in a small subset of women presenting with LUTs. It depends on the expertise, the kind of a know-how and the kind of work that we will give to such patients in future. There is no homogeneous definition or diagnostic criteria for female urethral strictures, unfortunately. Buccal grafts, vaginal flaps, all have actually come in and stood test of time. Follow-up will be always a challenge. We need to look at follow-up as a big challenge to us. Look at the Montosi series where I was a part of long time back, saw him do this initially. He did a 2-year follow-up on 88% of patients and was quite happy about them. Blavus and Olas actually had 36 and 53 months follow-up with equally good success rates of anything between 85 to 92%. We look forward to female stricture urethra, a challenge from diagnosis to management from this kind of platform that has been created for a neglected disease or disease which has not got that kind of a attention now, to get a worldwide or a national attention right from the first BOE. I think we'll take it forward step by step. Present to you probably 4 cases of combination of flap or a graft as the cases fit. We go live for the first case which Arvind is starting in OT1. Thank you.
Yes, so it was a really nice presentation from Dr. Pandey. He deliberated all kinds of procedure which is possible on behalf of the urologist to solve this issue of female stricture. Now, we will see how far we are going to sail it through the procedures. Dr. Panda will be showing you the dorsal inlay. That's an innovation. And Dr. Pandey is more of dorsal onlay. So, and if at all is possible, any type of flap urethroplasty also will be able to show you. Let me introduce you to the first case. It's a 28 years female. She has been suffering from obstetric LUTs for 4 years. This patient doesn't have an access to the tertiary care of center, and the patient was on and off treatment of recurrent UTI by the physicians or colleagues. When this patient got referred to us, we did an ultrasound and found to have a high post point on uroflowmetry. Let me. This patient had a uroflowmetry voided volume of 260 ml and uroflow of maximum of 8. And the MCU being shown over. Yeah, correct. This is the MCU picture. It shows a dilated posterior urethra, and we have already done that cystoscopy with a pediatric 9 French cystoscope. And for you, you are once again doing the same thing here. This is the cystoscopy picture. Yeah. I want to have an I need to have your attention. Actually, this BOE program, we have got a flash number which we are going to send us the SMS through WhatsApp only, so that we will be able to put this across to the operating faculties, and they will give you the answers right away. So do type the message and WhatsApp immediately to 94371 34979. This is being flashed in the USI website. This is the cystoscopy with a 9 French pediatric cystoscope with a feeding tube in situ, 5 French.
It's quite, you can see the stricture here, it's quite, it starts quite distally and it continues. If I just go inside, the stricture is still there, and almost till the neck, This is this is the pediatric scope. Can you just focus on the scope, please? This is the pediatric scope. This is the pediatric scope. You can see. Yeah, this is the pediatric scope. It's a 6 French scope, and you can see it's quite narrow. IFT just snug over that 5 French IFT, and here it is unhealthy. And the unhealthiness proceeds distally to almost the meatus. So, the key thing in the key thing in the female urethra is there are no landmarks, not like the male urethra where you have the veru as a landmark. So we will need to do cystoscopy each time we cut the urethra to make sure you're not actually progressing to proximally up to the bladder neck. I've already taken the stay sutures here, so we are going to save time, and I'll show you how this is done.
The buccal graft has already been taken. It's a 5 centimeter length with a 2.5 centimeter width. Buccal graft already been taken.
Give me the forceps. No, that's okay. That's okay. What the forceps there? Somebody else will get the leg. Give me the forceps. The same forceps you gave me? Yes, thank you.
Again, sir.
I'm going to incise the urethra. I'm going to incise it dorsally. Please give me the blade. Thank you. Yeah, so you can see it here. And
so this is the graft being taken.
You've got stay sutures, 50
See the graph.
50
It's a
vicryl.
nice, healthy buccal graph.
But this is going to bleed. This is extremely vascular. This is extremely vascular. And it's going to bleed a lot. You're not going to see anything initially. So, yeah.
Yeah, this is the graft being taken earlier. Okay, this is a 2.5 centimeter, 5 centimeter, more than 5 centimeter graft with 2.5 centimeter width. So it's a nice healthy graft. Due to constraint of time, we are not able to show the graft being taken. Over to Dr. Panda.
Suction, narrow suction. Narrow suction. Put this on, please. Put this on. Put that on. Put this on. This should be done initially. Yeah. Round body. No, it take cover kar de beta. Good. We are on live. Yeah, thank you. So basically, we take little bit of stay sutures close to this, and these stay sutures initially, because it's going to bleed a lot. You're not going to see much. Okay. Put a clip here, please. Okay, I will say one suture. So we will do this. Can I have another needle? Yeah. Yes, thank you. Cut this one. Quickly cut this. No. Cut this. Let's cut the short one. Cut the short one. Thank you. Put it here. Put it here. Cut this now. Yes, thank you. Can this be kept here? Thank you. Yeah. Okay, put this here. Here. You can use that later for something else. Yeah, cut please. Thank you. Now I will take the blade. Some jelly on this. Jelly. And I will cut here. Thank you here on this. Thank you. And I will just insert this here and cut. Make incision here. Can I have the speculum now? Speculum. Cold light inside. Cold light. Cold light. Light on. Light on. That's fine. Yes. Can I have the suction, please? Okay, no problem. Then I will progress little more here. From inside. Did you have a suction? Can I have a gauze piece? Gauze piece, dry gauze piece. Suction is ready. Suction is very important here. Give me the forceps again. Yeah, forceps. Thank you. You can see I have incised it, and now I am able to. Please keep sucking. Please keep sucking.
I will also need gentle saline, about 200 ml with some. Okay, you have to suck inside. Give it to me. Thank you. Yeah. Suction. Hold the suction. Suction. Yeah, great. That's exactly what I want. Right? So once you have excised this to some extent, you can put a speculum inside. Okay. Light inside, light inside. So we can see the incision here. Can you appreciate please? You can see the incision here and you can see the blood neck just. You can see very clearly this is inside the structure, and this is the part of the bladder neck, this proximal bladder neck. Suck please. Yes, that's it. Just inside a little more, little bit more. Oh yes, that's it. Okay. At this point of time, we'll see if I can go inside the bladder. Now you can see the my forceps which was not going inside the stricture now is easily able to traverse the stricture into the bladder. Stricture has been inside to the surface. Now the key thing is to have a good speculum. This is very important. As you can see, this speculum is very important. Ideally, it should be a little bit longer than this and a little bit thinner, but this will do as well. Then the speculum is inserted inside and then opened. When the speculum is inserted inside and opened, can we have a focus? You can see we have gone inside the bladder neck. Can you please show it inside here? Yeah. Now we have emptied the bladder. Now you can see where I have incised the. Can you appreciate this incision? Let me empty the bladder. I will show you in a moment. Yeah. Now you can. Now that the bladder is relatively empty, you can clearly see. Yeah. Can you appreciate this, please? Can you focus inside? You can see this is the bladder neck. You can see the bladder neck here. And then this is the area that I have incised. Can you appreciate this? Inside and show it here. Yeah, this is the area I have incised from inside, and this is stricture is inside, and you can see the bladder neck. Now I will just do a cystoscopy just to make it a little clear. So you can clearly see. Can I have yeah? We'll do a cystoscopy. The cystoscopy is to confirm two things. That one, you have incised the stricture completely, and two, also to be careful that we have not gone very close to the bladder neck. Now, while I agree that the bladder neck is not the only mechanism for continence in the female, it remains one of the most important. It is best to avoid injury if possible. Yeah, is this on? Cystoscopy is on. Okay. Now you can just see that. Now, yeah, that is it. That is the bladder neck. Okay, you can see the bladder neck there, and this is where my incision is. Obviously, I need to extend the incision a little more than what I may be a little more than what I've actually done. Maybe about 3 or 4 mm, maybe 5 mm more. I'll do that now. Again, you have to be careful that we don't extend it too proximally into the neck. So we put the speculum back again, some jelly on the speculum. Okay, thank you. And this is inserted right inside. Yeah, and can I have a knife, please? Yeah, please hold this. So there's a ring here, this small ring here which I'm going to inside.
Again, this is not a full thickness incision. This is cuts almost the 3/4 of the urethra, but not doesn't go beyond into the into the adjacent musculature. Yeah, I think the incision is almost adequate now. Okay, I can see the bladder neck and it looks okay to me. Now at this point of time, I'm going to leave it here. I'm going to go for the suture. Please give me the sutures. I need 40 PDS. 40 PDS. I use a dorsal inlay technique. I'm actually going to put the graft right there at the just distal to the bladder neck and then stitch it to the sides here. 40 PDS. I need 5 of those. Give it to me. Give me a good needle holder, please. And one long one. Yeah, this also with me. Yeah. Yes, correct. Now, please, can you show this, please? Yeah, this is how I hold the needle. Because this I'm going to take sutures right inside the urethra. It can be quite tricky there. Ideally, a 17 mm needle is ideal. This is 20 ml. So this needle is straightened like a ski needle. Please note this. This is straightened like a ski needle. A 17 mm is ideal. That is a very good needle. But we may not have that here. Doesn't matter. We'll do this with a 20. And it is held this way. This is the way it's held. This is the way it's held. And I would ask you to hold the speculum when I let you. Okay, thank you. Just now. Yeah.
Yes,
Now you can clearly see. Can you focus inside this? If you focus, you can clearly see the cut mucosa, and you can see the point where the intact mucosa is there. Dr. Debadarshi will hold the speculum for me. Please hold the speculum. Thank you so much. I will hold the suction. We suck here, and this I put inside like that. I rotate, making sure I come out. 1 minute. Release this, please. Release this, please. The suction. I want the suction released. Release the suction, please. No, I want the suction. Release the suction. Yeah. Thank you. As I said, a smaller. Yeah. Yeah, that you can see that it's gone beyond. As I always said, the smaller one is. Can you suck now? Yes. Yeah, this is the first. I want a straight. Straight artery. The ideal needle should be a 17 mm. I think a 17 mm is what I use always. This is 20 mm. This is a little too big to manipulate inside the urethra. 17 mm would just be ideal. That's a smaller needle. You get PDS in 13. Cut it, please. No, let that remain. Okay. Can I have it a rubber shot, because I'll be using it to put the graft. Oh, doesn't matter now. Okay, that's okay. Give me another one. One more PDS. I said I wanted 5. Please give me. Yeah, you can see I have taken that, and it's clearly taken there. I need more of it. Yeah, please. Thank you. As you can see, this is a 20 mm needle, half circle. What you really want is a 17 mm half circle round body. I cut almost the full thickness of the urethra, but I don't go beyond.
to cater the
Next one, next artery.
Straight artery located.
Okay.
Coming on WhatsApp. Let me interact with you.
Again, I've made it into a ski. You can see that. Okay, there you can see the normal mucosa there. So I'm going to put this.
Check.
Just hold that, please. Thank you.
Dr. Arvind, this is Dr. Prashant.
Yes.
Is there any special technique you use to
I use a
take
reverse
that bite?
Webster. I use a reverse Webster technique. You can all know that the Webster that was described for the posterior urethral strictures,
Yeah.
and I don't think it has been described to use dorsity on a female one, but yeah, I have to hold it like that, as you can see, and then I release this. This goes inside the bladder. I turn it, and if your speculum is protective, it should come out. The needle is a little big, so just 1 second. I am afraid that needle came out. It's a little big. I'll do it again.
This is something akin to our Turner Warwick needle. How we take it inside.
But
and
this is much this is much less traumatic. The Turner Warwick needle can be quite traumatic.
okay, fine.
Yeah, that's all it is. Can you please suck inside and show me? Just a second, show it to me. The needle is quite big, so it can actually traumatize the urethra. We don't want that to happen. Show it to me here. Thank you. Just okay. Yeah, I see it. Yeah, this is the second one has come out. It is much better, I think, to use a smaller needle than this one. This is quite big. It doesn't rotate inside the urethra so much. Yeah. Can I have one more, please? One more PDS. Yeah, now that I have taken two sutures there, the third one releases, please. Thank you. Now I just rotate this speculum little bit laterally, so I can take one of the lateral. You can see this one here. I will take a lateral bite here. This one comes here. Thank you. Yeah, thank you so much. So again, this way and out. Suck, please.
This is opened. The needle goes inside and then comes out. This is much easier. It came out easily. Laterally, it's a little more easier. This was the third one. Can I have a curved one, please? Then the straight. Okay. You can actually take curved and straight. So make sure your orientation is correct. Okay. One more. I will require 5. Please open 5. I will require more than 5 actually. I might require 6. So kindly open 6.
Dr. Arvind,
Yes.
how do you make sure you have taken adequate issue? Do you give a gentle hug?
Yeah, I give a gentle tug, and this is the. I'll just show you this technique again. When you're doing this, you need to. The actual motion is you dorsiflex the wrist and they go inside. So it's not a pushing motion. It's not really a pushing motion. It's not really a pushing motion. Look at the wrist. It's not really a pushing motion. It's actually dorsiflex that wrist and then they go inside like that. So this is the way you dorsiflex that wrist and they go inside like that, making sure that they're taking a big bite.
Okay, fine.
And yeah, this one on the other side. Yeah, would you please? This one has to go here, please. These stay sutures are very important, because unless you have taken these stay sutures initially, it will be very difficult for you to, just a second, it will be very difficult for you to, and I cannot of course reiterate the importance of having good, yeah, this is it, this is here, can you just stretch this? Yeah, now you can see that part which is I have to take as suture. Thank you. So I go here, as you can see, I go here inside and I move my wrist. Yeah, so I take a good bite. Yeah, you can see that. That's come very nicely. Now, have I not had cut through? Yes, I have had cut through, as had anybody else. So, and when that actually does cut through, you have to take it again. And then here, it's quite easy. It's much easier to take it laterally. Yeah. You have to, of course, confirm that you are taking mucosa. Yeah, you have taken mucosa here, or maybe a little deeper. Can I have one more, please? I don't think the mucosa has come here. Take it again. Give me that. No, this is okay. Give me that.
So how many sutures do you intend to take?
Normally
proximally?
I take 5. Normally I take 5.
Okay.
So this is my 4th, and then one more.
All 5 proximal edge, or there will be 3 on the proximal and 2 laterally, or something like that?
Yeah, 3 proximal and 2 lateral. Actually, in this case, even 4 is okay.
Okay.
You don't have to take 5.
Fine.
This one. No, this is not okay. Suck, please. Okay.
This is the urethral tube.
Suck.
Neck.
Give this to me, the friend. Release this.
So you don't drop off the urethra?
No, I do not drop the urethra for a very simple reason, because I feel there are nerves there, there's a lot of nerves, a lot of vascularity there. Just hold this gently. There's a lot of nerves, a lot of vascularity there, and there's no advantage to be gained by dropping the urethra there. Yeah, this is the mucosa come very clearly beyond. Suck, please. Yeah, there you are. I think in this case 4 also is quite adequate. Yeah, clip please. Now we remove the speculum.
Retractor, other organometer, sort of
Dr. Arvind,
Yes.
a question from Dr. Saurav from
Yes.
Lucknow.
Yeah.
He wants to know the retractor what you are using
Yes.
and the other ergonomics what all you are using.
Yeah, the retractor actually is a nasal speculum. It's a nasal speculum. Ideally, you want a long one. About this one is a Scott retractor. This is the standard Scott retractor. The retractor I'm using inside the urethra is a nasal speculum, a Killian nasal speculum. I need to scope once more. So this is ideally you want to have a 9 centimeter long length. It should be longer and thinner. And there are speculums available called the Killian's modification, where this part is slightly beveled. And if this part is beveled, there is more. The access is easier. And ideally, this groove should continue well towards the end of the blade. That will give you more space inside when you're actually trying to take that bite. Anyway, I just do a scopy to confirm my sutures and to confirm that I've actually indeed gone across the stricture. It is very important to do scope. Yeah, are we on? Yeah. So you can see that there you are. You can see that the bladder neck is intact. The bladder neck has not been inside, and the incision starts right here. And there are my sutures there. This is the bladder neck, that's intact. I have not incised beyond, and this is where the incision starts, and this is where the sutures start. The sutures are actually on the mucosa, and all of them are quite. Yeah, here's one suture here, the other suture on the other side, and there are actually 4 sutures like that. That's okay. I think I'm happy with that. No, the bladder neck is intact. No stitch on the bladder neck. No, of course not. You don't really want to incise the bladder neck. Can we have the buccal mucosa? Some genta saline. Yeah, please give gentamicin saline. Put the buccal mucosa inside this. Yeah. The buccal mucosa is put inside the gentamicin saline. I just do that because that comes from a non-sterile area. Maybe a little bit, maybe 15 minutes. It doesn't harm. Can I have a Caesar, please? Fine Caesars. Yes, please hold this. Thank you. This is enough. This much is generally more than enough for in a female. This is the good graft. Caesars. Fine Caesars. You'll have a Caesar here. Yeah. And this is nicely defatted. I just have this is nicely defatted. I don't think I do anything more than this. This is quite nicely done already. Basically as thin as possible, but not too thin. Yeah, that's okay, that's fine. It's nicely defatted. I don't think we have to do anything more here. Yeah, put it back. I just want to confirm my sutures once more before I finally use the speculum. Here you can.
Can we use local skin as graft?
Yeah, you can use local skin, but there is no problem in using local skin. It is more difficult to handle.
And I think the chance of contracture will be more with the
Yeah,
skin.
you can see this quite wide here. And, well, okay.
Why do you refer a EMG as opposed to a graft from the local vaginal mucosa or something?
I think that can be done as well. The local graft is possible. It's just that I'm more used to a BMG. There's no particular reason. Can I have the sutures, please?
Yeah, there.
This is the first one. Yeah, please. You can just hold this, please. Suction to me, suction to me. Yeah, needle holder.
Dr. Arvind, I feel this is one of the most important steps here. The way you take this sutures on the graft.
This basically is outside in, so inside out.
Exactly.
And can I have a Caesar? Just a Caesar. Yes.
Now the raw area is facing up.
Yeah, the raw area is facing up. Okay, this is going to go inside the
Exactly.
urethra. It's a pretty long graft. So, can you just hold the graft with the forceps, please? Yeah, just hold that. Hold it up. Yeah, thank you.
The suture is going outside in, right?
No, inside out here. Inside the buccal area. So because
okay.
outside in initially, now inside out.
Now inside out, fine.
Yeah. Can we just hold this? Yeah, you can put that back there. Then the second one. Oh, I don't need suction now. I will let you know, please. It's very easy to suck the graft into the suction. There's no not required. Yeah, please hold this. Hold this, please. Thank you.
So all these three sutures have gone proximally,
Yeah,
right?
they've gone beyond the strictured segment.
Beyond the stricture segment.
There's finally the fourth one. Now you can see the graft is right there. This graft I will just push inside and suture there. Now before I do it, I need the gentasaline, please, with a syringe. You need to actually wet the monofilament sutures. That's very important. You need to wet the monofilament sutures before you do this, and wet your hands as well. Okay. Now I would request Dr. Debadarshi to kindly hold this one, and brother, you can just hold this. Thank you. Just hold this gently, and this as well. Dr. Deba will hold this. Just will. Don't stretch too much. Keep it slightly loose. Not too much stretching. Now I'm going to tunnel the graft inside. At this point, okay. The key thing is to make sure that you're tightening this thing well. The danger is sometimes it cuts through.
Actually, I have had instances where it has cut through has been there, and that is the advantage of taking little bit more number of sutures.
Yeah,
even
I
if
take
one
5.
goes,
I take 5 actually.
exactly. So you can
here.
afford to let it go.
And I think the needle is crucial here. I think
Yes.
that 17 mm needle would be ideal.
Yeah. Because once there is a cut through, there is no way you can go in and take a
No,
suture
it's very
again.
difficult. You'd redo it again. Put clip. I have a clip here. Put the clip back, please.
How many nuts you usually take?
5 to 6.
5 to 6.
6. Okay. And I make sure that you are holding it. They are holding it loosely. There's no real tension on that when I'm taking this. That's okay. Beyond that, please. Yes, thank you. At this point, you have to make sure that there's no infolding of the graft. Just hold this, please. Can you just pull this thing out a little bit? Yeah, just hold it like that. Thank you. It's very important that you prevent infolding of the graft. Yeah, that's okay. Thank you. You can release that. I'm going to cut the short thread here, scissors. Yeah, cut the short thread, and the long one will of course continue. Clip on this and final this. Can you just stretch this graft also like we did the last one? Thank you. A little bit. Yes, thank you. Inside. 2. Clip on this.
Dr. Arvind, there have been this apprehensions about incontinence with the dorsal technique, but I guess most of them are unfounded, right?
I have not encountered incontinence. You are quite right, because a lot of features, a lot of structures which contribute to continence. In this technique, at least, because we are not cutting deep, and we are not dropping the urethra.
Okay.
And we are preserving the loops around the urethra. I don't expect much incontinence. So you can see that graft is taken there.
Yes.
And I'm going to cut the. Can I have the scissors? I'm going to cut these 2 sutures.
Okay.
Not much roll of. Can I have suction here, please, at this point? Yeah, this is cut, and This is important. This has to be lateral. Kindly hold this. No, yeah, thank you. Suck again. Yeah. And you can give me those two bits. Those bits which have come out, long bits. Give me those long bits, long suture bits again. Yeah, one more. Yeah. Can you give me the needle holder? Yeah. So this is something I use to hold the graft up. Forceps. Yeah, forceps is here. Here. Something I use to hold the graft up. I just take one. These are stay sutures basically. Yeah, just clip it and keep it the other side. Not too tight. Yeah, gently. Yeah.
Dr. Panda,
Yes.
have you come across any patient
One more?
with Otis urethrotomy?
Yes, I have, and
prior.
they are not very good candidates for urethroplasty also post Otis urethrotomy, because it doesn't work. In my opinion, making a deep cut will cause only fibrosis. It doesn't work. I don't like Otis. I don't do Otis. It's a blind procedure, and I have seen complications post Otis, so I'm not very fond of Otis. Yeah, there you are. Now you have the graft here.
Otis vis-a-vis dilatation.
Which
is bad?
I much prefer dilatation to Otis. Because I feel dilatation is far less traumatic and causes far less spongiofibrosis than the Otis urethrotomy. It's okay to put the patient on dilatation, intermittent or regular dilatation, but you see that if you put those two sutures, you have excellent exposure, and here you can put a speculum or something, or you just look at it. Can I have some suction here, please? Yeah. Yeah, the speculum. The longer speculum, as I've always said, is far preferable to the shorter one. Can I just hold it gently? Yeah. Yes, you can. Now you can clearly see, and because the graft is stretched, now we have to take sutures inside, and a smaller needle always helps. I think the. Yeah, there you are. It's difficult to take with this big needle. Okay, thank you. You can remove that needle, please. That's this speculum now. Yeah. You can remove that now. Yeah, thank you. Suck from there. Yeah. Now you can clearly see it's only the first one that you need it for. Then it's mucosa to mucosa coaptation. Make sure you're taking only the mucosa. This is a continuous suture here. There you can see this side is almost over. This coaptation is done, and I'll take one more and I will stop. We will complete the last interrupted later. Can you put a clip here and keep it, please? Yes, thank you. Then the other side. Oh, not this one. small. Yeah, thank you. You have to bend it right to almost a semicircle here. This is quite crucial, that almost a semicircle when taking that last suture. Can I have a speculum again? Thank you. Can you hold, please? Thank you. Can you just hold this? Can you focus inside? Can you focus inside this thing? You can see it very clearly. You can see that very clearly. No, inside this. You need to come from this angle, from the other angle. So you can see it very clearly from the other angle. Come behind my my right shoulder. From here, from this angle, yeah. So you can clearly see that is the edge of the graft. Yeah, here. Come from this side. Yeah. You can clearly see the edge of this graft. You can see the edge of the urethra. Are you able to see both? This is the edge of the graft and this is the edge of the urethra. I'm going to take a suture here. I'm going to close it right. This is very clear here, I think. Here? Yeah, thank you. I think there's a white balance issue there. You can take it back, thank you. Now I'll just take a suture here. Again, when you're taking a needle inside such a small place, it's always better to have a smaller needle.
It's a nice exposure actually.
Yeah, but you need to have a smaller needle, I always say. It's very difficult to rotate this big needle
Anybody
inside.
can say the sutures line.
Yeah, but it's very difficult to see this, do this.
Needle is bit longer.
Yeah, it's a little big. So I'll do it the other way. I can do it. It's not that I cannot be done, but suck, please. Suck here, please. Suck. Yes, you can remove the speculum now. Thank you. I have taken it. Suck there. Yes, once that is there, you clearly seeing the edge. And you can just pull it and take. Yeah, release. Thank you. No, I think there's an issue here with this. This is. No. Please give me another forceps. Another forceps, please. It's sort of interlocked there. I'll just take it out and continue. Suck there. Yeah, this is the interlocking. This suture is interlocked, nothing more. Yeah, now it's fine. Okay. Suck, suck. Kindly hold this. Thank you. Okay, so now you can see the graft is sitting well there inside. Now the point is that this graft has to be quilted, otherwise it's of useless. So can I have one more bit? I'm sure there will be a bit somewhere. Or give me a new suture bit, whatever you want. Clip on this, the graft. Please give a clip on this, yeah. Give me a quilt, give me a new suture. Can I have a smaller 3/4? No. Anyway, quickly. Thank you. So this is the point, we have definitely have to quilt a graft. So you need to take it inside and okay, so just to confirm, yeah, no, release please. Stuck it inside. There should be a little bit of tissue there. You can see it if you like. Yeah, that's, you can see that it's gone through. Okay, you can put this back. Cut both. Both, please. Thank you. I think quilting is very important. I think the graft has to stay fixed. Yeah, this is a vascular structure and it can bleed very badly, and you have hematoma inside, and then your graft will not survive. Quilting is important, and I also will make a few small holes after I have finished this. For me, quilting is one of the most important steps in any urethroplasty. I quilt a lot. Some people don't quilt. I think it's a matter of your philosophy. Again, a small needle is good for quilting. It doesn't traverse very deep, but traverses enough so you don't go into the other structures which are beyond the urethra. Yeah, cut both, please. The difference between this technique and the other dorsal onlay techniques are, I do not mobilize urethra from the top, so maybe I feel it preserves the nerve supply and the vascularity, and also the sensation of the clitoris. Tinta short. Good. Cut both. So at this point of time, I think we have to just bring it out and see how much extra graft we have. We need to cut that extra graft out, and we can take the graft up to the vestibule. From that, we'll cut it out. Can I have a scissor, please? Oh yeah, tissue scissors. So this is where the graft comes. So I think beyond this, there is no point. Yeah. Please preserve this graft. I might need it eventually. Thank you. Yeah. Yeah. I don't know. No, I don't know how it is going to work out. Let us see how it is. I just hope the graft will take.
You're on the mic?
Yes, I'm on the mic. Cut, please. Yes. No, that's okay. Let's leave it. Let's hold that. Yeah, thank you. Yes, please hold this. This is and testing and take it out and just hold this a little bit. And yeah, I think that's done. Can we cut the long one, please? Only the long one. Yeah, thank you. Hold this. Release this one. Cut both, please. Thank you. Yes. I'll repeat the same thing on the other side. Yes, please. That's it. That was the entire surgery is almost over. We'll just put the catheter and close. Thank you. Camera can shift. Yeah. You can shift away. You can shift the camera, please. Thank you. Can you cut this one, please? Cut both. Camera is gone. Okay, fine. Now we can work safe, comfortably, na? Camera is on the. No, wait. This area, na? Is it raw area or is it cut? If it is cut, that small graft I'll put here. Now is it okay? Is it mucosa intact? Huh? Intact, na? So, you want, I'll put the graft. No need, huh? The small graft I've got for this.
You want me to get up?
नहीं कोई नहीं स्टार्ट कर ଆମେ ଜାଣିଥିଲେ ତୋ ଭବିଷ୍ୟତ କଣ କଣଟା ହେଲା ତୋ ଭବିଷ୍ୟତ ମୋ ଭବିଷ୍ୟତ ଏଇଠି ବା ହଁ ତୋ ଭବିଷ୍ୟତ ହଁ ହଁ କେବେ ଲାଷ୍ଟ ଟାଇମ୍ ଜିନିଷ ତ ଅଛି
सोलह थोड़ी हाँ सोलह सेट चलो चले
କହିବି କହିଲା ପରେ ଦେଖିବ ସେଇଟା ଦେଖେଇବ ସେଇଟା ଶିଖେଇଥିଲି ଖାଲି ଖାଲି କରିବି କହିବି ମୁଁ କହିଲା ପରେ ଏଇଟା ଦେଖ ଏଇଟା ଅନ୍ କର
मते
ऑन तो So, we have come to the end of the first case. It was a very nice demonstration by Dr. Pandar about the dorsal inlay technique. The technique itself says how nice the female will void after the surgery. Let's see how far. This is the second case. Coming to the second case, it's a 27-year-old lady, has a voiding dysfunction for last 8 to 9 months, been dilated once in the month of December. After that, she voided normally for a couple of weeks, then narrows down the urinary stream. This is the recent uroflowmetry. This is the uroflowmetry. This is the uroflowmetry. Voided volume of 390 cc with a maximum flow rate of 8 ml per minute, and the voiding time is so long, 85 seconds. coming to the MCU, you can show this MCU. This MCU shows is not, the posterior urethra is not being dilated, and it's a uniform urethra narrowing. We did a cystoscopy with a 9 French pediatric cystoscope, and it showed the whole length of urethral narrowing and the fibrous segment. Now it's over to Dr. Pandey.
Am I live? Am I audible? Yeah, sure. Good afternoon, everybody. A wonderful demonstration by Dr. Arvind back in the other theatre. While we were waiting for the surgery to start, we decided to go ahead and prepare the buccal mucosa. And just to show you, we harvested approximately 4 centimeter of buccal mucosa, defatted it and kept it there, ready for a placement. Kept it as broad and rectangular as it could be, and kept it defatted to the normal thickness that I would like to leave around. Not too much of defatting. You can just focus this and just show that part. Yeah. So that's what is ready for grafting dorsally. This happens to be that's fine. That happens to be a dorsal onlay technique. Just to give you an idea of what we do here. Thank you for the retractor. We could, with a bit of tightness, pass in a 8 French feeding tube, which is there in place. I've just closed it to prevent getting wet. We have 2 stay sutures on the at 3 o'clock, and I'm stretching 3 o'clock and 9 o'clock. This is to give the inverted U-shape incision, which I would be choosing here to make the onlay. And we have an incision on the anterior urethral wall. I'm going to be somewhere between all these to actually take a very close look at the urethral wall as I go dorsally. Can I have the knife, please? Okay, can we look at that? Okay, just a gentle stretch on that. So as we stretch, the U becomes a V. Yes, I forgot to tell you, we just injected some Xalocaine adrenaline with a 26G needle, periurethral, which would, and we'll look forward to how we move forward. So keeping very close to urethral wall, right from the level of the incision at the meatus, all the way while dissecting. The cystoscopy in the morning showed, look at a fragile looking mucosa dilated approximately 2 months ago, as I'm told by the host. She continues to have a poor flow. Urethra was quite raw. Can keep it dry all the time. Okay. Can I have scissors, sister? Scissors. Yeah, take a section possible. And keep around there. Yeah, there's a section on there all the time. Can the table go down a shade? So I've got my plane already. Suction there, please. That's the plane I want to tow. I want to leave all the muscles and the collateral complex just over it. So I will be actually doing a very thin flimsy line on the urethra all the time. A suction there, please. Asiva sister, take her on to. Take her on to. Yeah, Tani ke rakhte ho, take her out, please. Okay. My dissection is completely dorsal. Not going to travel to lateral on both sides. It's all about me creating the plane. And that's where we are. Out. Out, please. I'm able to show you the plane. Can you focus on this wall, please? Yeah, can you just focus on this wall, and for a while can we dry it up and just show what layer I am on? That's the anterior urethral wall or the dorsal urethral wall. That's the urethral wall which I'm on. Okay. Suction, please. Good. Somewhere you have to keep mopping and drying it up around, and yeah. Okay. Out, please. Out, please. As we settle into place, we'll be able to show you better. For a while, I'll take my scissors inside and show you. Yeah, keep sucking that area. I wish I could show you better. Gauze piece, please. So that is very important to start with. Majority of the female urethral strictures will be distal, distal 2/3, distal 1/3. Don't want to traumatize any. Can you see that? Just move it out, please. So that aspect I need to safeguard very well. That will be my 12 o'clock incision as I move in. So I am trying to keep completely on the urethral wall all the time. There we are. I wish I had a head camera to show you how clean and neat it can be seen. Can we just go to the table a little bit down, please? Yeah. So I've not cut anything other than the incision, and that I've used this wonderful Meds and Bomb scissors. Dr. Debadarshi, thank you for the scissors. This actually is letting me move on the anterior urethral wall with ease. I must confess there was an induration at the level of the meatus and induration, but the very look of, so I am all the way in there. I'm moving in there. Yeah. The way tearing it up, we know it's a friable looking urethra. So to continue on the anterior urethral wall, dissecting, abutting exactly on the wall, and staying between 1 o'clock to 11 o'clock, but as my where are incise. I will now go in with my forceps and look at situation. Can I have a stay suture, please? Catgut 3O. Chalo. Don't do it. Can you see that? So retraction देबे होता है. Retractor देबे सकता. छोटे retractor थिला. धन्यवाद. So okay, just take this inside gently. Be there. Yeah. Can I have a stay suture, please? And then. So you dissected half the length of what I want. Next half is crucial. I need to be completely in my plane. I won't incise till I have reached quite a considerable location yet. And give me a second. Just need to take a stay suture. Now, these were 3 o'clock and 9 o'clock stay. I'm taking a stay to just keep a mild traction without tearing it. Can you retractor there? Retractor there. There you are. That's for urethra. Suction on there. Super. Keep drying it around. John upor asiki. Gauze piece doctor sobbale gote. Okay. Okay. Here you are. That's the urethra. That's the one I want. If I take a stay suture, I'll be better off. The stay suture will soon come out. It's a guide to me to help me in retracting. We train to be perineal surgeons, but not necessarily vaginal surgeons, and it adds to a little bit more practice on this. Please come. So just please cut in. Thank you. Leave it to me. gauze piece was basically to keep the hemostasis for a short while. But a peanut milwaukee. Okay, can I come out, please? Can I come out? Thank you. Okay, can you go back again with the retractor here? Awesome. Can you be on the suction? Give the suction to me. For a while, if you could focus and show us the white urethra, which I could see from here, the lights and the angle required. My colleague is able to retract it well inside, and I'm able to get the plane which I want to move in around. Okay. Yeah, just be there. Okay, so there you are. So I can now show you that I actually got 3 o'clock, a 9 o'clock, and a 12 o'clock. And this 12 o'clock is what, keep doing suction here please on the anterior wall. And that's the dry anterior wall. That's the urethral wall which I show you. That's what I would incise when I move forward. Okay, so let's move inside. Can I have the retractor gradually go? Yeah, can you just do suction on the anterior urethral wall? Great, good.
Dr. Sanjay, this is Dr. Prashant. This,
Yes.
how do you know how far you have to go? How proximally you have to go?
Yes.
When you have reached the bladder neck?
Yes, bladder neck is still far away. I am approximately 1.5 to 2 centimeters in the urethra.
Okay.
There are multiple ways to look at it. One of them will be the catheter, a smaller bore catheter going in and me tugging it around. The final way is that. But as I move forward, I'll be assessing my length. Now I'm approximately 1.5 to 2 centimeters inside.
Okay, sir.
Cystoscopy is the only way internally to know that we have reached close to bladder neck. This patient has got a stricture going very close to or short of bladder neck, both seen on the MCU as well as out please. Out please.
So would you do a routine scopy now, a urethroscopy
On
to?
table cystoscopy is a good idea. At some point we could show the audience what are we dealing with, but not pre-operatively. We have just done that. I am trying to now move in.
Okay.
Yes, at some point we could do it. It's just that an add-on time issue, but
Okay.
we could show them when we incise that we are at the bladder neck. I will just finish the dissection part. It's only a head-on camera on the surgeon's head which could allow us to go all the way.
Do you want to?
Pardon?
Hello.
Yeah, go
I am
ahead.
Dr. Suren Das. Do
Yes.
you want to have a Hager's this calibration with a Hager's dilator?
That will help me to incise all those structures which I have.
Because till what point you are reaching just sort of stricture
Yes,
or not?
yes, we could actually do that too. I would, if chance, take a scope directly and show the audience where I am. So what I'm doing is, I think is visible now. I am on the anterior urethral wall all the time. You can just see that. No. I am on the. Can the camera come just behind me? ऊपर से हाथ मत लाओ. I am on the anterior urethral wall all the time. No cutting anywhere. Just separating all the tissues which are basically the cavernous tissue, the spongiosal tissue of the clitoris away, and moving deep enough. If I just look at where am I, I'm this much deep inside already. That's what I've gone in already. So which could be the size del mate. I would actually take a scope if Debadarshi, if you allow me. I'm approximately 2.8 centimeters inside the meatus with a gentle minimal stretch. And apart from the ooze that you see, there's no active bleeder because I have been on the glistening surface of urethra all the time. So it's a dissection which was facilitated initially by the medicine bomb. I don't want to puncture the diaphragm there. We would look at some point planning an incision, and Dr. At some point my incision would come, but do you think I should take a scope, Debadarshi?
Scope.
You have
Scope keh rahe, scope de. Dede. Scope.
Well, I am done with my external till I have a look at what etc. we need to do. So chotiya peanut dewe ki?
Scope dita thila amara career utila.
Chotiya peanut dewe. So I am able to go into that plane. Chotiya peanut dewe na. बहुत छोटिया जोड़ा हजी बनी. So now that we have got this, time to actually take a scope and then think of looking at how more to dissect before I incise. Go to zoom in କରିପାରିବେ ठीक है zoom in କରିପାରିବେ section yeah ना पछपट आसी ठीक है I just want to show the audience the location of my dissection. This is the anterior urethral wall. ଏଇଠୁ ଆସିବ ବକି ଟିକେ ହାତ ନେଇକି ଏଠି ଆସିବ ଗୋଟେ ମିନିଟ୍ ପାଇଁ पूरा ଭିତରୁ ପୁରା ଫୋକସ୍ କରିହେବ forceps चलो खाली गोटे मिनट के स्टैटिक रखता तू just to show that the glistening surface of the anterior urethral wall because I will then move to the next level. Yeah, am I able to show you that that is the anterior wall of the or dorsal wall of the urethra where I am able to walk in now. There has been no cutting other than the incision made as a U shape on there, and that is the surface of the urethra. We are hemostatically okay, and we are actually on the surface of, that's the surface. देखिए उची, that's the surface.
Yeah, probably you have reached just short of bladder neck.
Pardon?
You
Yeah,
have
I'm
reached-
just short bladder neck. I mean, you could guess it. I'm on a traction.
Okay.
So I want to be very sure before I incise and then place a large bore catheter to look at does it go. I'm approximately 3 centimeters inside, and I would look at a cystoscope before I incise and then look at. So that's a turn out there, and I need to be very sure that I'm in the right location. This is the one. So the corporal bodies, the collateral bodies have all been taken up. That's the urethra dissected up. So that was an kind of a dissection along the urethra after that U-shape incision. I'm almost ready to look at a scope and then make that incision at 12 o'clock to plan my angle sutures. Okay, can we have a cystoscope? If not, then we do scopy in the next case, just in case there's a logistic issue. Okay, don't touch it. What a dry gauze piece, delete, shigra. Okay, don't mate. Go to scope connection, shigra. That's okay, leave it. So I'll just leave it as a gauze piece there towards the hemostasis in the plane that I've created. Okay. But lets me dissect and at the same time doesn't touch anything between the two walls. Okay. For a while you can just come out, sir. Thank you. Just come out. Yeah. And we'll wait for the scope. Okay, come please. Don't. Connection. So what I have is a stay suture on the dorsal urethral wall at the meatus. I have a stay suture on the periurethral tissue taken above. In between the two, I've got a plane on the anterior wall, and I'll be moving now just to confirm where I am, and then my incisions. Like so. I got a wolf ureteroscope and Pani. Yeah. Come. Come, sister. Jelly diyantu mudhe. Jelly eti diyantu mudhe hatara. Come, au diyantu ठीक है. Saline diyantu. Asun. ठीक है, पाक्को नहीं आसी. पानी खोला अच्छी. पानी खोल दियंतु. Ready to go. पानी खोला अच्छी. I'm already inside the bladder. I will come back. Little bit issue with our, you can see that telltale signs of dilatation at the level of bladder neck, but the bladder neck was capacious when we did a hydrodistension kind of a picture in the morning. And that's where after it coapes is where our pediatric scope would go with a lot of tightness as shown in the MCU. Only when I would incise and take a catheter, just to show you the inner aspect of it. I've not cut anything yet. I've dissected anteriorly. I will not know if I've dissected till the wall. So telltale signs of dilatation 2 months ago. And that's the urethra at the level of mid urethra. And I'm coming out now. A distal urethra. This has its own induration to the pediatric scope. I'm using a longer ureteroscope. I can't feel any grating around, but I'm out now. Okay, Niyantu. We'll keep all this system for a short while. I will now make an incision, and I will look at a 16 French catheter. What are the catheter we're using? Are you getting a 16 French silicone as a catheter? Take it away. Can we be back, please? Okay. Stay suture on the anterior urethral wall is basically used to incise the urethra. And can we concentrate here, please? Camera. There. Scissor. What's up? Are there any questions meanwhile from the audience? Yeah. Okay. 8 an hour. It's time to incise. There's a lot of glare on you. It's time to now incise urethra, which I show you the anterior wall. So that's anterior wall for demonstration. There we are. So that will be my incision deep inside. Suction all the time from above. And I will now like to take this inside to look at what level I am. What you now see is the incised urethra.
Dr. Sanjay, there is a question.
Please.
Do you get urodynamics in every case prior to surgery? And would you proceed with surgery even if there is elements of overactive bladder?
Elements of overactive bladder would be either secondary to the obstruction, which could be treated medically. But if you have an obstruction, you may have secondary overactivity all the time. Important that we look into that aspect. So urodynamics will be a part and parcel of extensive workup on patients, because you are committing to a reconstructive surgery to improve the quality of life on the basic aspect of primarily obstruction, Secondly, overactivity. Would look forward to working up those patients who have continued bothersome symptoms on a low dose anticholinergic if required, but you already have an obstruction. Suction, please. I wish I could show you inside. Yeah, that's it. Yeah. Okay. Okay. I've actually incised all the way till I dissected. Can I have a 16 French catheter or 18 or 20 French catheter, whatever suits you? What is the catheter you open for me? What is xylocaine jelly? Keep it dry all the time so that otherwise with the glare there's nothing visible. It all looks all in one. Jelly debe. Okay. Okay. Don't go inside. So I'm looking forward to if there's anything else left over, and I go with a bit of tightness, but I'm able to move in. I will have to look at dissecting a shade more, please. Not happy with this. Come on, take this, please, sister. What did you want? Okay. So I've got what I wanted. I'm still short of the exposure I want to do. Sister, I'll need 2 stay sutures. It's a feeding tube. Don't dig on the wall. Feeding tube. Dry gauze piece. Dry gauze piece, please. We'll have to dissect some more. We're not yet reached what I wanted. Okay, come. Stay suture ready. Okay. You have to show me that. Now the feeding tube actually shows how much I have dissected and divided. Okay, so we go down. Go down. Okay, that's my limit of dissection. I've not dissected beyond it. So I'll have to go in and dissect more before I'm allowed to cut. Okay, now. Suction inside, please. I need some suction inside. Good. I can see the anterior vaginal wall. I can see the anterior urethral wall there. And being on that. Once I'm able to. So now a gentle dissection along the anterior wall. Yeah. Can I have the suction in my hand because we are all busy obstructing the field? Yeah. So I did some incision along the anterior wall, and then I would do a little bit of separation of the tissue there. Also fine. Also fine. Okay. So we'll again go and look at revisit the urethra and take stay sutures around, sister. So get my stay sutures ready before I incise. Stays, catgut. There are 2 walls. That's one wall you can see there. Forceps, please. Forceps. And that's the second showing. There's the other wall of the urethra. Can you go inside the lumen, please? Yeah. Can the camera angle be changed a bit to show us? Yeah, so that's the wall. Scissors, please, sister. Scissors, please. That's nice. Looks like a peanut butter here. One stay here, one stay there. Catgut. Approximately a centimeter inside, I take my first bite. Can you just take a stay on this quickly? Clip on this, please. So now I need to incise that suction inside there, please. I dissected that approximately 0.75, which I want to now incise. Can table go down a little bit, please? Get the table down, please. Yep. The next stay, please, quickly. Table down, please. Dorsally cut. I've been approximately 2 centimeter. My catheter is still tight, and I just saw that I need to approximately go close to 1 centimeter more. Yeah. So I'll play safe there. This is the lady with the longest stricture we have today, isn't it? Is she the one? Yeah. Need to go right down there where scissors, please. Right down there where it is. Okay. Next will be to look at this. And do you have the nasal speculum, the thin long one? Okay. I wish you could show the inner aspect of that. Just to take this out for a while. Section there, please. I would not use a force. I just like to look at what I've done on the anterior wall. More of an assessment. Can the lights go in? Yeah, good. Yeah, perfect. Looking at all that we have done till now. Okay, that's the limit I have done. Can I have the suction in my hand? Yeah. I'm still short of my. Yeah, so is it possible to show this? That is the point of segment I want to. Now posterior wall, anterior wall separate was a feed tube. Hold on. Yeah. Wish I could show you this. I'll stretch myself to show you this inside. This is very, very important. And this patient who has got a stricture very close to the bladder. Pura Bitarasi antu. And I will suck up. That's a great view. I'll just suck and show you what I want to. I'm still short of. Yeah. So feeding tube, light focus on that. Yeah. So what I have done is I put that feeding tube across the last part of the stricture segment. I need to incise that stricture segment for me to take stay sutures. That is the last segment which had the catch, and we are approximately close to 3 centimeters inside the urethra. I will dissect. And then I will move out and start the dissection. So what is visible is the posterior vaginal wall. What is visible is the posterior vaginal wall. What is visible at the apex of this is the stricture segment still there. That for a short while. Awesome. Okay. That's a stricture segment still there. After I've gone 2.8 to 3 centimeters inside, I need to incise that. So I'll do a little anterior dissection here. Get the stay sutures on both sides at the apex. Incise this and then place the graft. Okay. Thank you. Here. Okay, sister, I need back the scissors and out. Okay, we go in again. Be there. You're doing well. Thank you so much. Sister, I need the feeding tube back. The feeding tube is a good guide for me at the angle, and I'm moving in that direction. That segment, which is still the stricture segment, is tied to this feeding tube. Okay. Right. Can I have one more retractor system? Can you give me these retractors? I would stay laterally rather than midline. How would I do it? This one goes down. Section now. Section inside now. Good. Very good. Thank you so much for that. Okay. Okay, fine. Now, can you show the anterior urethral wall there? That's the urethral wall there. I'm able to show you the urethral wall on this side, the urethral wall on this side, and again continue dissecting on top. Let's go there. Can you stop there, please? So, can you zoom in a little bit? More. Yeah. Yeah. I'm doing the same technique again, staying on the glistening anterior urethral wall. Yeah. The same thing I'm going to do on the opposite side, where I've got the stay suture approximately 1 centimeter inside. Okay. Now you will show me sucking inside. The retractor back system. I need to do that last part very well for my field tube. Right. Okay. Retractor देवे तो चलना. Okay. ऐसा. थोड़ा सा इसके ऊपर भी चल जैसे. इसके ऊपर. Yes. Yes. Good. Show me that. That is one wall, and that's another wall. Okay. System sense catheter. Catheter, please. With some jelly. Or just cut 0.75, 0.5 kind of thing. So it hits my anterior wall now. Give me a stay suture now on the apex, otherwise it will hit. So it is going in that angle, or it's hitting my apex. Yeah. It goes ease. It hits the apex because the apex is not supported by a stay sensor. Suction on that please. Okay. Sister, I will need a PDS. I will need the nasal film. That's fine. Okay. Super. I need to create an angle now. This one. So all I would need now is to have nasal speculum, my first 2 bites. To look at okay, there we are. Okay, suction inside please. As I place this, yeah, okay, I'm in the lumen now. Just to give me the catheter once. First the catheter. I'm just trying to stay short of the bladder to prevent urine falling down. At the same time, my apex is visible. Can I have the suction in my hand? Would not like to enter till the bladder neck for a very specific reason of basically I would like to be very careful about that region. My angle is down. Can you see that? Angle is down. I need to look at that angle. Okay, hold this. Okay. Give me a minute to assess the whole thing. I'm okay with it. Not the sister. What a space is there. Light inside, please. It's okay. Over inside. Have some suction inside. Exactly. Don't go deeper than that. Just fall short of that, please. Wonderful. 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 Very good. Very good. Long needle holder. Longer needle holder. Get me a long needle holder to enter inside. Yeah. Section. We got a clean to देते हो सर. Clean to देते हो. Clean to का देते हो. Clean to. चलो.
urethra to be visible completely to you as I take a bite. If you can just suck that dry. Super, which is super. Just be there. See that? Scissors, please. Scissors there, please. I need to create some more apex because the apex is so minimal, I can't take a bite here. Yeah. Nice. So very gently I need to create some more apical wall. The apex is entering as a V. I need a little bit of dorsal dissection for the apex to be open. And then section of this side up there. Very good. Look at the steel features once. Look at the steel features once. Cut this system. Yeah. Clip back. Clip. Out. Okay. Right. Section. That's fine. All the time. Suck that. So that's my apical bite on the wall on this side. But a pretty deep bite, therefore I need some vision inside. Good. Finally, we'll have to get the water on me. Remove that. Keep sucking as you scroll. Okay, next suture. Next stitch system. Yeah, so that is the technique which I did because my apex was. That is next stitch system. Out of scissors. Clip. Clip. एक आर्टरी को तो दे ले next step system Whatever organ needle lagega, I'll go in out and take the needle and then inside. This one has to be kept tight. This one, then we go across. Let's see here. Such a tight. Turning in. Yes, just keep it there. Very good. Thank you so much for this. Apex. Now go to the opposite side. Apex. Go there all the way. I'm taking an in-out bite on this side because I will have creating a got it. Out. Just out it will be. What काम करें? Ready बोले? मैं आप पीरियड से आपको काम करें. बरोबर. Yes. So this bite is in out. I need a needle. I needle. Okay, suction back. I've taken inside out on one side, outside because the angle of movement was tough. All I have now to do is to take the central bite and then put the buckle on that. For a while, can I have a catheter here? Our period लगेगा सिस्टम है, एक हम बाहर करेंगे, ओके? What is inflation देवे? Inflate करें उनको balloon 10 ml. जोड़ उठे. I'm just trying to look at if I can show a little bit of urethral walls to you. All this time we have been showing you blood, but yeah. So I've taken a stay suture, subterminal on one side, terminal on the opposite side, and that is my urethra all the way. If I tug, I'm on the bladder neck. I can show you the mucosa inside now. This is mucosa. Wish you could come inside. Show the apex of the PDF last. And that is what I need to take a bite of. See that? That is my apex, which I am actually tugging along with the okay. I have actually gone in all the way and got my healthy apex. I wish. Yes, can we? So
that is actually nice.
That is a soft and supple urethra.
Yeah.
I want to show you the urethra which is parchment and white here.
We can mop it once so that we can see it clearly.
I want to show you the parchment white. Can I just see it? Boss, please. I want to show you a parchment white urethra on both sides. Actually, there is a. It's only my. Yeah. So.
Yeah, it's fantastic.
That is what I want to show you. The parchment white urethra.
Yeah.
And inside that is the pinkish urethra which I just incised.
Correct.
Now I need a guide to actually take a bite. Yeah, that's a normal urethra there, very close to bladder neck. And that is what. So I'm just giving a gentle tug on the whole thing. And now I will be able to take that bite. Okay. It's a little bit on a traction right now so that I can take my angle. Which there was another holy way to this. At the same time, I don't want to injure the catheter. So now I would create a space between this and the healthy urethra and take this. Mind you have to be very careful about removing this catheter when a bite goes in. Catheter out system. Catheter bar kar do. nurse is helping me remove the catheter as I take a bite on the urethral wall, not going any anterior than the urethral wall. Yeah, take it out please. Thank you so much. And I need to travel there. Okay. Okay, thanks. I wish. देखिए बारी बेटा. बेटा needle का देखिए बारी है.
Yeah, it's clearly visible.
Needle visible?
Yeah, correct.
Thank you so much. So that needle is from the angle which I wanted. In
Exactly.
the and I have to
It's in the 12 o'clock position, right?
at the 12 o'clock position, out in.
Correct.
Gentle traction around and
It's nicely visible.
wanting to prevent a injury or a cut. I will check this twice, if not then I'll go in again. And you can see that
Yeah, it's tough also.
it is a tough one, which is good enough. देखिए पहुँचे बेटा, हाथ लगा.
Yeah, yeah, it's everything.
Good enough. So we have got that.
You can see there also.
देखिए
It's
मुझे ना.
clearly visible. Yeah.
Good, thank you, sister.
Very nice.
So now we have got the 3 apical bites around, and approximately, I would say 3 centimeters plus. I've just given traction to every aspect, but at the same time looked at that tissue above it is not buccal mucosa. Please don't pull it out.
So bites at 11, 12 and 1.
Yes, so 11,
Or
12, 1.
10, 10, 12, 2.
Artery. So I've got 1 o'clock, something like that. Yeah,
Okay.
I've got that area covered around. Got a mosquito. Got a mosquito. The polyjuice system, a towel. Okay, so remember what is what. Okay? Right. Everything Anand. Ready to focus करिएगा.
Craft.
So I'll take the midline stitch. Somebody will pass me the stitch. Take the
It's
needle.
nicely defected.
Yes,
buccal
I
graft.
defaulted it to the limit. Keep this with yourself. Needle holder sister. छोटे needle holder. I'm inside the lumen. I'm going inside the lumen again, which is the mucosal aspect. That's the first bite. Can I give it back to you? Apply that, please. Yeah, go ahead. So just attach. Attach it and then give me the next one. You getting it? Yeah. Attach both together. Attach both like that. Yes. Attach it there. Perfect. You give me this. Sister, the needle is Chuchi to it. Chuchi after two. Okay. Leave it for a while. Give me this one. That is should not fall down. Give me the 1 o'clock now. Okay. The reason is I have gone in out on the left, on the right wall deliberately to get the best of my bites around, and then I have to come out in and suture it outside. Okay. This is in out because I am out and on the urethra at the left angle. I'll clip this at 1 o'clock. Okay. Just attach it, clip it back and take it away. This is the apex. This is the apical stitch, and then we suture it inside the apex. Getting it? And the main part was the dissection part, and then finding the apex, getting the 3 bites on the apex, like any anastomosis. What I want to do is, I am outside here. That up. So I will have to go out in my suture. My knot will come inside. So hold it for a while. Possible achieve? Maybe possible. So tell me, in case possible. Model choda. I'm just waiting for the needle. I'm sorry. We had to take a very careful bite on the angle on the opposite side, and I did not want to traumatize it. And that's it. So this is the mucosa. When we stretch, it will become 4 centimeters, but 3.54 is what is required. So and then we fix it up bilaterally. This part gets quilted onto the comparable bone. Okay. Okay. I gather we will have to take this out. The needle is in out. So I will go. Okay. This one I'll have to make a change there. Debadarshi, I'm taking it out in now. You're outside, so you're taking out. Then I'll have to mold it there accordingly. Forceps, please.
In difficult situations, when you are dealing with this kind of suturing,
Yeah.
lot of times you are not able to take out in and in out. So is there any problem post-op like formation of stones and everything?
Not actually has to be looked into. That is what is important.
Are you worried about all these things in post-op
These are
period?
delayed absorbable sutures. There are colleagues who actually keep some of the knots inside. I am being very careful about the apex.
Okay.
Very important. And that
Since-
is how it is.
Since you don't go deep inside to the bladder neck
No.
and knots inside the bladder, so I don't think any problem and issues will be there post-operatively.
I'm being safe. My angle should be good. I should be able to. That's it. So all about now knotting it inside and taking it inside.
Nicely the graft has been tied up.
Yeah, so the graph will go in as I take
Yeah,
my
correct.
knots around.
Correct.
Which I will start with the 12 o'clock ones. So just left the graph there. I look forward to taking my finger inside and going all the way as deep as possible. Thanks. Debadarshi, I have been able to place it where I wanted. I want to cut through there. I'll have to put this back a bit and take a bite of that. Because a good bite, but we pulled it out. Oh, yeah. So this one will go up. Like that. Yeah, come back, hold it there. Yes. Catheter also there. Catheter also there. That's it. One more. Come on, catheter. It's up. Separate it a bit. Loosen it up, please. Like that. This one's more stitch wide. Keep away. Scissors. Scissors system. I'm going to cut through an apex. I'm going to go back and do that. Okay. Inflation. Inflate. आगे करेंगे तो कोई core inflator system. कौन है ये जगह? इधर Silicone କଣା ହେଇଛି ଆଉ ଗୋଟେ କ୍ୟାଥେଟର ଦେବା ପଡ଼ିବ ମୋତେ ଲାଗୁଛି ସିଲିକନ୍ ଖୋଲିବ ସିଲିକନ୍ ଖୋଲିବ suction don't put the take a back on here yeah one plus okay carrying assistance just don't pull up be gentle with the switches that's nice long needle order long needle order
ଲଞ୍ଚ କଲେ ମଧ୍ୟ
5:15 ପହଞ୍ଚିଛୁ ମୁଁ ଏଠି
5:15
5:15 ମୁଁ ପହଞ୍ଚିଲି
ऊपर टांग के आपको प्रमोशन मिलेगा आपको प्रमोशन
ସାଇଡ୍ ଦେଇଛି ଏବେ ପରା ଦେଖାଇଥିଲେ
Okay, yanked a little bit extra than I should have. We're going back in terms of tightening it up. So this is the way to do it. Just keep it loose and let it go as I pull.
Dr. Pandey,
Yes.
Earlier the first case Dr. Panda
Keep going inside.
told that
Keep going inside.
he is not dissecting
Yeah.
the intercavernous, interclitoral and urethral layer
Yes.
to preserve the continence at the same time to not to disrupt the vascularity
Yes.
and the innervation. How do you take it?
No, that's a very good technique. The inlay technique will be all about less bleeding for sure. There will be lesser bleeding. The continence mechanism is preserved if we stay on the anterior urethral walls. Let it fall down. The continence mechanism is preserved if we maintain the dissection along the anterior urethral wall or the dorsal urethral wall. You saw me do, and that is what is most important. So there are many ways to build a cat. That's one good technique. I saw the presentation. Extremely impressed with the technique around. We need to be armed with armamentarium with multiple techniques around in case required, but need to practice our own technique all the time. So that was a very good technique. I like that. Yeah. Loosen it up, please. That's fine. So I am completely in sync with that dissection. But as I said, there are multiple ways to dissect. Just leave it alone, please. So that is one good way. I just delayed the procedure by yanking the stitch there, so I'm going back again. I pulled the buccal mucosa back and we're getting back to work. Okay. So now we go inside. Now because we did a little bit of mix up there, so I need to fix up things again back in place. That's nice. Okay, can I have the wash and then the cut system?
What is your take on lingual mucosa graft?
Lingual is, we have not tried in females yet because many authorities have still used something called labial grafts, labia minora graft, the vaginal wall graft, and have we used vaginal flaps. You can also use vaginal graft. So I've not used lingual per se. Lingual has come in male urethroplasty in a big way, and a vision tray we could be able to use it here too. But then you have got so many more grafts to take. Buccal mucosa heals very well. 3 months down the line, you are capable of taking another buccal mucosa. So possibly could be a way forward and patients to be able to take grafts. So it may not be the first resort unless you're using lingual regularly. Scissors, please. Scissors,
What do you think about the take of the graft?
The take of the graft is related to both the bed which you are keeping it on and the technique of keeping the give this please. Taking off
Take of the graft, shrinkage of the graft. That is the most important thing while you are using graft.
yes.
Post of shrinkage. How much you expect the shrinkage?
Well, like any partial thickness which shrinks, is also a partial thickness but has got its vascularity.
1/4.
Its lamina propria is quite leave it please. Let me take this in. Yeah. So there is a partial shrinkage and therefore in today's world we don't defat it completely, number one. Number two, we don't stretch these grafts and take sutures around. So in both ways we are completely in sync with keeping the bed. So what he did was inlay where he did not touch the bed at all. What I did was I dissected along and now I'm able to finally be able to complete this. I'm very worried about the friable nature of the mucosa we have here. And I actually traveled on the surface of the mucosa. And therefore I expect a friability, I expect a bit of tear here. Need to be very gentle with my stitchers and with my colleagues who are assisting me around. We will not to okay, so that is done. Can I have a scissors? We completed both sides angles. We have taken the midline. This side angle please hold. And mix it up. That's the midline which I was keep the time. And there is a please keep this way on your side. These are two sutures which will continue. This is one bite which I want to complete by tying it. This is your thread. Attach it here, please. Okay. And this was because the tie has come this way. So basically, I have placed my angle, which was the most important in a friable structure. After a limit, externally, I will not be able to see it, the graft. So I will now pull it up. Can you hold this for a short while for me? Okay. Let me assess before I go in. Xylocaine jelly, please. Yeah, can you hold this also for me? These ones, without any traction. So I will go through and see. And that is, it moves in freely. The graft has gone inside. I'll take that later. Not required. I was just trying to assess myself.
Exposure is quite nice.
Yeah, so I just checked myself where I am, and now I'm good enough to go tie the middle one and take my stitches around. So that is basically sutured and tied from outside. This is the middle one. Just hold it forward.
What is your opinion regarding quilting?
Quilting happens by the two sutures that we take transversely on the two lateral edges. There are a few quilting sutures which can be placed. You can see me going deep inside now. That's an important bite. I should not yank it again. But as I suggest, I had a very friable mucosa at that edge, and I have to be very careful. Yes, quilting happens more in my technique by taking the two bites on both the lateral sides, leaving a vaginal pack for 24 hours, and taking few bites out here onto the. I don't take any bites here in the midline like we do urethral male quilting, because we have the corporal bodies up there. You may actually either bleed them, or you may injure them, or you may do something. None of them would serve our purpose.
What about the clitoral sensation post-op?
Clitoral?
Sensation post-op.
This is the one technique compared to Dr. Panda's technique where if you are not in the right plane, you can actually be looking at both incontinence as well as clitoral neurosensory injury. But none of them would be in my favor. So you saw me do a yellow clock bite like this because I had a little choice and be very careful about. That's my 12 o'clock. Can I have? So neurosensory innovation. Okay, take this away, please. And these two are my angles around, and then I'll continue suturing. Okay, now I need to have some.
That looks great.
Look at the depth. Again, where I was. Suction to me, please. And can I have the forceps system? Now again, need to go back. I need to have some xylocaine jelly when I go inside this. Yeah. That's how it is. So if things go well, I can just suture both sides.
Correct.
You can see the posterior urethra. I was showing that's the posterior urethra wall between the edges, and both sides are the edges which I will now suture as I come out. So that's the posterior urethral wall, and I create a notice. So we get going now, please. Let me have that catheter.
Can you show us the urethral cuts?
Yeah, I'll show the urethral
lateral cuts.
Keep it dry, please. That's the urethral edge all the way. That is 1 centimeter inside. Leave it, please. That's the urethral edge. Please don't let it fall. That's the urethral edge on this side.
Yeah, that's great.
Can I show you that?
Yeah, correct.
Yeah. Sorry, we have limitation of the camera can move in. So that's my urethral edge. The other urethral edge, which was here, has got a bite which has been taken, and that is here. All I would do is now start suturing both of them. Yeah. So that's deep inside.
Yes, able to see now.
Yes. Close as a 2 centimeters. We'll take bites on both of them. Okay. The catheter. Really? Sorry. এটা বন্ধ করে এটা বন্ধ করে এটা বন্ধ করো কেটাও কলা লগাই দেখি Suction, please. Suture on your side first. Okay. So it's just show the lumen and just to show the urethral edges that kept the catheter inside. I'm going to drop my buccal mucosa which is getting dried right now. Take a pani deve. Come, give me that. Okay. Okay. Sister, can you hold this, please? Can you hold that? And can you hold your stitch? That's urethral edge. So again, as deep as I can. As deep as I can. I'm being very careful here and trying to be. Dekha jauchi. This is a very deep stitch as a subterminal suture, and suction somebody, please. You can leave that there. Just get into some suction. Yeah, go ahead. Because I don't want to pull the buccal mucosa inside. Okay. Okay, give this to me. Drop it to my side, please. Okay, and suction over that. Yeah, suction over there. Okay. That's nice. Leave it, sister. Okay, can you just keep holding it up? Now I'm pulling it a bit. Can I have a suction here? Can I have a suction there? And then we're going deep inside. Okay, move up. And then I will place it there. Okay, can you take this up, please? Thank you. So basically the sutures now know the urethral wall well, and that should be a completion on the side of this wall. Yeah, so here I encountered a friable urethra. I would have torn it more beyond the cystoscopy we did, which was tight. I wanted to go on the dorsal wall, keeping very close to repairing over a 16 French could actually repair over 18 French. Whereas we got a large 1.5
So
centimeter.
you're taking continuous suture, right?
Yes, I have after the first two sutures taken continuous.
Is there an advantage between continuous and interrupted?
I'm just not locking it. It's a 2.5 centimeter. There's no major advantage. I won't be compromising the vascularity of the suture line anyway.
It will be faster, right?
Yes, I mean it's a small segment compared to what we normally do. There you are. And there. Okay. Okay. So no traction on the mucosa on any side. Okay. Come there. I sub and I'll hold it there. I'll just hold it there for a while without any traction and just leave it there. We go to the opposite side, and sister, can I have the needle, please? I cut all the catgut sutures now, which will stay on both. Needle quota. Eta needle to. Eta rakthan to eta tar angle. Take it away, please. Yeah, good. Thank you. Awesome. Okay. Thank you. So again, can I have a little bit of scissors and cut all the catgut sutures to make it less confusing? Okay. Leave this alone, please. Okay. That catgut goes away. These are catgut sutures which were the stay, and that we have got our own stay sutures. Please take them away, so it's least confusing for you people to assist. Yeah, and then now needle eti era sister kote lagai rakhi dentu. No. Okay, come. Hold this, you, and just follow it up, please. Forceps koti, sister. Forceps, huh? Okay, let's go inside, please. Suction all the way. The deep bites will be again similar. You'll have to take this away. I have to go all the way approximately 2.5. So I'm going to pull this. That's the urethral wall. First bite is okay. Suction inside, please. Suction inside. All the way. Okay. Okay. I need a little thicker white. I'll get this catheter out and I'll go all the way inside like that. You getting it? I need to go a little deeper and find my needle come in all the way. Section. Yeah, I'm going to do a traction on the urethra when I do this to pull this out. Leave it, please. Yeah. Okay. Get that? Okay. Take it up. Okay. Dry, please. Yeah. Yeah. Leave it. Take a hand in. Yeah. That's nice. So I confess I had a little bit of trouble in this urethra which I was scared of tearing completely. A little friable when I saw it in the morning on cystoscopy. Want to be very sure I'm going to preserve the lumen all around, which I've been able to get now, and finally looks good. Looks satisfactory to me. Okay. Are there any questions, Debadarshi, which I need to answer? Okay, that's nice. So approximately 4 millimeters away are my sutures. I've taken 5 bites, on that side 6 bites, and okay, give it to me. Only one more bite to take. Should wait. Give it to me. It was a bit of nightmare. We broke the middle suture and then we were struggling to get that middle bite. And now we are coming to the end of it. Okay. I don't cut normally the mucosa till I've completed the last part. I need to take the knots here and then maybe make a decision about what does the whole thing look like. The meatus, important aspect, you don't want the meatus to narrow around, it's more of a spatulated meatus. That will happen here. Can I have some water on the hand, please? Thank you. Can you cut them both? Yeah. Cut. Be ready. Next step. Okay, take this away please quickly. Can I have the opposite one? The last bite and then we finish it off. And then we fix up the meatus. Can you just keep it clean? Wash up. Okay, hold this. That is the buccal mucosa. The lateral bite. That's my end of the urethra. That's the lateral aspect of the urethra. So I'll take the last bite on the urethra and tie it off. Leave it to finish. Okay. Thereafter, I would need a closure with those bits. So this was a different technique from what you would see. It's all about dissection, possibly in patients who have undergone multiple dilatations. There are two things, kind of spongiofibrosis picture where the urethra could be hard, fixed, or it could be friable urethra. Any of these two with this technique could be able to be dissected all the way, keeping in line with the dissection that continues. I would now look at removing stuff and suturing, removing extra. Can I have the tractions off and all these first? So just keep it gently up for a while. Can I have some xylocaine jelly and then the catheter going first, and then this whole thing will be set up. Scissors for a while. Okay, I should take that angle sticks to the inside. Okay, take it away please. I will take this traumatic one out. Yeah, so we'll take some of them out. So can I have, sister, can I have xylocaine jelly and catheter? Can I have some wash here, some cleaning up? That's it. And then my urethra has to go up, and then it's become part of the meatus. Some xylocaine jelly on the tip. And I need to travel under the buccal mucosa all the way. Can I have forceps? Take this on. And I need to see, don't pull too much, just keep it gentle. And my catheter should be going in an angle. I have to create an angle again. I could actually love to do a cystoscopy now and look at the angle that I've created. Don't pull too much. Yeah. So that is basically the, don't pull too much. That's basically the urethra which we have. Nice. Give me some xylocaine jelly inside. And that's what it is. And you can see, show the meatus. Whereas meatus has to be fixed up into the cut which is there. So that will now retract up. This will go. I will take some quilting here before I keep the catheter, otherwise I'll have to take it. I don't have much extra left over, I have only this much, which I'll cut in the end. Scissors, syringe, force good than so that's how I would leave a little extra redundant meatus Debadarshi at the tip, which would help me to, and that is lumen which I've given compared to what we would not have been able to enter. I need some xylocaine jelly so that I don't traumatize my suture lines. And then this will be sutured around it. I have left a little extra amount of mucosa there. I have not removed everything. You stitch the other way, catheter. Take a bit that. Long bit. The issue is about the catheter. Normally we keep the catheter for 2 weeks, and catheter normally we keep for 2 weeks, suction up there, because I'm trying to bring back here. There's a way to quilt it up. I will dare not, because here we have got the catheter bodies around. So
that is the most important thing what we are talking about right now is the follow-up of the patient.
yes. So
2 weeks catheter removed, then how to follow?
Yes. So now people are
You have a uroflowmetry on the same day?
she should pass urine, should be comfortable.
Okay.
Check the post-word residue. do a uroflowmetry a week later, 2 days later,
Okay.
and then we will have to follow it up very closely in terms of.
How often?
There is a school of thought mentioned that they follow every 2 weekly for the first month, and then after every month, and then after 3 monthly till the end of first year. Now Montorsi and all did follow 3 monthly for the end of first year, and thereafter.
The patients were called on telephone and were asked about their flow. They were called for a 6 monthly uroflowmetry. At the end of 2 years, most of the patients in Montorsi's follow-up, even in Olos and Blaver's follow-up, 88 to 95% success rate, what the quote, was good enough for them to stop their follow-up, but the patients did not decide not to come longer, or the papers published have talked about follow-up only till that point in time. So I would look at a follow-up longer in our place, but when the patients do well, either they see our colleagues, they shift towns and cities, or they stabilize at a point in time which I and you would identify as a stricture. For them it would still be continued better flow than what they were. A small subset of patient Debadarshi could actually land up with a requirement of a calibration, and those are the patients who underwent I've kept a small amount of buccal mucosa between the stitch lines that I normally have. In other words, I've given a spatulated analysis anteriorly. You can see that I'm suturing the buccal mucosa to the previous inside lines. Flush and just some water flush, please. So that's my, you can see my urethra. That's my urethra around. I'm playing only with the ventral wall. Dorsal wall is playing with all safety.
Looks nice, boss.
Yeah, so I just want to add this point that I had incised the urethra here, but I am actually suturing the buccal mucosa here.
Yes, correct.
In other words, I am adding a spatulation to the
Correct.
meatus or the meatus, because that is the structure I am suturing to,
Yes.
which is my U.
To the buccal mucosa. In other words, I'm adding a spatulation and a lot of healthy buccal mucosa here for it to grow.
Correct.
Jelly, please. Yeah. So that is what it is. That's my ventral wall, and I would like to leave a catheter there for approximately 2 weeks. That should help us. I've created an angle. I have not done a spatulation anteriorly. I'll be extremely safe to play.
Fantastic.
So you can look
that
at that.
goes with
This is what is my
without
spatulation to the
resistance.
meatus. Yeah, so it's walked in freely. I know
Correct.
that anterior wall is not quilted. We leave a vaginal pack here, inflation debe. And other than the friability, which I quote again and again in the midline at 12 o'clock, which I was worried about tearing it, we are okay with one suture which we yanked. This
As
procedure.
you all can see that this is the silicon catheter they are using. It's a 16 French silicon catheter.
Prefer doing 18 French.
Preferably 18 French, but they are using 16 French.
Sister, mate VA debe ki.
So for the postgraduates, the follow-up of the patients post-operatively
How
is
bit achi
you
eta?
have to follow. You have to take
Yeah, how
out the
bit achi?
catheter after 2 weeks. Then you have to follow the patient every 2 weekly for 1 month. Then
I normally
every
don't
month,
immobilize the patients, but we are looking at inosculation, imbibation. Request the patient to be having the pack till tomorrow evening, 24 hours. Request the patient to be in bed till 48 to 72 hours. The catheter can be fixed in such a way that it does not give a shearing effect around. So what I've done is I want to point again, give an extra amount of cut big, yeah, extra amount of meatus anteriorly by adding that broad urethral. I know there's an out of shrinkage where Dr. Debadarshi asked. Can we take this off, please? And that can this be removed? Go ahead. Please. Thank you.
So we have come to the end of the second case. Is a nice demonstration about this dorsal onlay, where we have dropped off the urethra, we cut it ventrally, and we have stitched the graft onto the wall of the urethra. So where we were is the how to follow up the patient post-operatively is.
So what I've left is, as I said, a little bit of. Thanks. Yep. Thank you. Thank you again.
So you have to follow up the patient after 2 weeks for catheter removal. You have to do a uroflowmetry. You have to go for a ultrasound to know the post-void residue. Then every 2 weekly for a month. Then every month for 3 months. Thereafter you have to follow the patient every 3 monthly for 2 years to know the status of the patient and how the patient is voiding. Now we are moving on to the third case. This will be operated by Dr. Prashant Nayak. Let me introduce you to the patient first. It's a 55-year-old patient.
Yeah. ಅವನಲ್ಲಿ 8 years 8 ಹಾಕಿ ಉಠೇಗಿ 8 ನಾ ಸಿಸು ದರ್ಕರ್ Yeah, I think this is okay. For me, just to have an idea that what they are saying. That's all. Out here, upper hele, let us have it.
So this patient, can you focus here?
It on करो.
Hats off to all the surgeons, since it's a open surgery, tidy surgical procedure with very much of concentration is needed, because it's a small space, 4 centimeter space, and they need to put more effort for suturing, to take the bites, for hemostasis and all. So introducing you to this case, it's a 55-year-old lady who has got complaints of obstetric gluts for last 4.5 years, with regular dilatation for every 3 months. She is improving with dilatation, and the streams worsens within next 2 to 3 weeks. This is the current uroflowmetry report, which shows of a voidum volume of 193 ml She is having only 7 ml per second of the maximum flow with a voiding time of 43 seconds. This is the MCU which shows a dilated posterior urethra with a narrowed anterior urethra. So we did a cystoscopy with a pediatric 9 French cystoscope, and it showed a anterior segment of urethral almost around 2 to 2.5 centimeter stricturous length, which with a fibrous segment. So we planned this case to do a ventral inlay. So let's over to the operating surgeon, Dr. Prashant.
Thank you, Dr. Debadarshi. At the outset, let me just thank the Board of Education and the IMS SUM Hospital with the team of Dr. Debadarshi and Dr. Soren and Dr. Evabrath, who have given us the opportunity to do this. And thanks for taking up such an important topic, which is close to my heart. And we see so many female patients who were denied this operation for such a long time and who have been undergoing repeated dilatations. And we are here and with the hope that this operation is being taken up much more frequently by others who are watching this. As Dr. Debadarshi has told you guys, this is a female patient, this is a female 45 years old with history of repeated dilatations, and each dilatation gives her relief for a period of 2 to 3 weeks at max, and she again comes back with complaints of obstructive flow, and it needs another session of dilatation. Right. So I have already prepped the patient. The labia majora have been hid with the labia minora here. So we have the urethra is in here. What I will be doing is something called ventral inlay. Ventral inlay where the graft will be placed. So as you have seen in the MCU, this is almost extending up to this mid-urethra area, and I can feel a step in the region of the mid-urethra. So this obstruction extends from the meatus up to possibly this mid-urethral area. Right. You just have to take out all the urine. This is called vagina sparing ventral inlay urethroplasty, where we are not making any vaginal incision. We will be just incising the urethra on the ventral aspect, creating a rift in the urethral mucosa there and trying to bridge the rift with the buccal mucosal graft. A little bit of infected urine. Can I have the knife? Can I have the 11 knife? Is it possible for you guys to have a look? No? Now is it seen? Okay. I think image is a bit blurred. Can it be focused? I'm still not happy with that. I think it's better, yeah. The theoretical advantages of doing a ventral inlay are less chance of incontinence, which is because the structure of the external sphincter is supposed to be ohm shaped, and the major bulk of the tissue will be lying on the dorsal aspect. Here, suck here. Can the light be focused a bit inside? Can it come down a bit? Can I have the knife again? Yeah, section there. And see. Yeah. Can I show the knife? Yes. I have to keep it like this. You have to adjust. Either you go up or something, because the moment I do this, the is the AC not working or something? Let them get it in place. Fine. Is it better? Yeah. Just give me the knife. So once you keep it under tension and you incise it, this opens up here. Suction, please. You can see this is the mucosal edge here. That's the mucosal edge on the opposite side, and the intervening tissue opens up. Yes. Is it seen? Yeah. Now we can see this. Is it seen? Yeah, you can see this. The idea is to incise ventrally and then give some traction so that the mucosa opens up here in the area that I've incised. See, you can see the mucosal edges here, and you can see the submucosal area opening up there. Okay, and I have the speculum, please. Aliens, it come? Yeah. Yes. Just. Yeah, X कर देवे हाँ. Yes.
Dr. Naik,
Yes.
how deep you are cutting the urethral mucosa?
At this point you have to be careful. You are just cutting the urethra and little bit of the submucosal tissue. You are not going beyond. There is a theoretical chance again of higher incidence of having urethrovaginal fistula, which has not been seen actually in the reports. So although it's theoretical, but just keep it in place. Yeah, I think just keep it like. Now you can get a very clear view. I am having an excellent view of the area. I don't know whether you guys are getting it. Fine. So if you can see, you can see the normal healthy mucosa there. and you can see the area that has been incised, and you can see the urethral edges. Right?
It's very difficult to go see inside.
Yeah, I think it's. Yeah. Yes, I think the view is better. Yeah,
This
fine.
view is better.
Fine.
You can use the cold light.
Yeah, if the cold light is there, maybe you can appreciate it better. Just want to see because you can
this
very
is
clearly differentiate between the normal mucosa and the mucosa that has been incised.
exactly. This is the most important step.
Once you have it like this in front of you, then this rest of the part becomes very easy. We'll just wait a minute so that you guys get a good view, and then we'll proceed. Just a little bit down. Yeah. You have to give them the way here. Yeah.
It's a full thickness incision.
Yes, full thickness. Yeah. Good. I think now it's
Yes,
seen.
yes.
Right. Can I have EDS, please?
What are you using as a graft?
Graft will be buccal mucosal graft, which has already been harvested and prepped and kept ready. I use a vaginal graft also sometimes, but
Proper vaginal graft or oral labial graft?
any of them. You can either use a vaginal mucosal graft or a labial graft. Can I have 2 arteries to straighten it? Yes.
Yeah, it's a very good question has come from Bhubaneswar. When we say that
Another one.
after urethroplasty, any kind of urethroplasty, it's a substitution augmentation urethroplasty, any type of dilatation or intermittent catheterization
Will
is
be
called as a failure.
Yes.
Do you agree
I agree
that
with that.
is there with this female stricture also?
Yes, actually the tradition, what has been reported is about 80 to 95% success, and those studies have told that even one attempt at a dilatation would constitute a failure. So this here I wanted to show you guys how to take this bite in a bite. You can see this margin between the normal urethra and the abnormal stricture area. So if I can show you, it is very difficult to go in and take it like this. So what I do is, you go in like this, which is easier. Once you wedge the needle between the normal and the abnormal mucosa, you just rotate it up and then you go in. So that makes it easy. You wedge it, you rotate it, and then you push it up. It has rotated within.
That is very nice technique.
Can I have
what you are
another
demonstrating.
needle holder? This one I'm not holding it. Can you give me a bulky needle holder? Yeah, I think that would be better. Yes. Suction plate. Wedge it, rotate it, and then can I have a needle holder?
This is at the 6 o'clock position or
Yes,
the little
this
bites?
is, this is at the 6 o'clock.
Okay.
Once you
Since
hold
you are
it,
not looking, you are not able to look into that.
can I have a long on-tooth forceps? Long non-tooth forceps. This point is crucial. You have to get a good bite, otherwise, while manipulating the mucosa inside, it will It'll get lost. Yeah. Action, please. Non-tooth, non-tooth, non-tooth. Give me that forceps. It's too thick anyway. No, I'm not getting. I want a long non-tooth vascular forceps or something. Give me vascular something. While grasping at his earring, so I am not getting a good grasping here. Just a minute. Do you have a longer killians? No, we have only one killians. Close it. Okay. Yeah, that is it. ठीक है, से टाइट करिए वो. Yes. Can you focus the light? Yes. It is important to get this right because, yeah, it's done. Just give a gentle hug on it and we know that it is through the tissue. Fine. Can I have another one? Hold this. Yeah. Artery forceps to straighten it. Artery forceps. Suction, please. Light. And if possible to rotate it, I think it loose कर देले भला. Rotate धरलो, just hold it. Yes. Just a minute, just loosen it. बाहर आसी जाउची, it's coming out. Okay, just hold it. Give me. बस, same तो बेसी ये दबने. I'm taking the other bite. I need a heavier one. It bhari le rotate. Not happy with the instruments. This needle is rotating. No, you're not. Suction, please. Yes. There, it mate de there. Yes, can I have the forceps? Yes. No. And strong. Okay. Okay. Bleeding right on my head. I can't see anything. Light, please. Light, light. Light. No, can I have another needle, please? Or you give me this thing. It pura bunka hai gala. Just become. Can you give me another one? Yeah. Fine. Okay. Okay. Give me the needle holder. Okay. Just hold this. Okay. There it is. Give. Just give. Yeah. Can I have it? Just hold this. Hold this here. Yeah. Suction, please. Yes. I got the other one also, the second one. We need to take 3 proximally and 3 distally and 1 or 2 laterally. So the second proximal is done. Give me the middle one. Yeah. Eita diyo. Se je chota ta hegala ko sete se houni. Yes. Hold this. Yeah. Hold this. Let us Sabat, if we just rotate it. Yeah. Yes. এটা ভিতরে these needle holders are not very strong. I need a very robust needle holder to hold it, because the moment I am rotating it, it is rotating with the needle holder. The light there, light there. Yes. Yeah. Yes, just keep it like that. I think this is, let me see, this looks robust. Select here, review. Yes. Yeah. Give me that thing. Out. Yes. Okay. Fine. Very good. The, this needle holder makes the difference. This is you have to be able to arrive it in. The moment you're rotating it, if you don't have a good needle holder, it will rotate with it. Can I have it? I'm not happy. This has slipped out. I think we'll take the middle one again. Yeah, hold this. Yes. Hmm. Huh. Action inside. Yes. 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 I think most of the things you are not able to see from here. Huh. Action, please. Suction, please. Just hold it. Just give it to me. Huh. Can I see the light? Give me the needle holder. I can see the area. Only thing is, it has to rotate and grab. I'm happy with the other two. One that is at 4 o'clock, another is at 8 o'clock. So both are fine. I need to take a good 6 o'clock bite. Yes. Just take this out. I think it's causing some hindrance. Yeah, this is getting lost in the Hillian. Just a minute, just a minute. Yes. Fine. Yeah. Just give it to me. Yes. Yeah. Hold this. The upper mucosa is coming. Yes. Okay. Fine. Okay. Okay, give it to me. Yeah. Fine. So all the three, you can see this is the region of stricture. This is the mucosa here, and this is the mucosa here. So there are three that mucosa and stricture area we have taken 3 bites. We have taken here. I can get the graph. And I have the needle holder that you had given me earlier. No, the other one. Previous one. So this needle holder was not holding it robustly. So when you're holding the needle here, it was just holding, and when I rotating, the needle was slipping out of it. So this is what hit the trick. So this was holding it robustly. Idea was to go in and then rotate it and then hold it with something else, release it and take it in and come out. So you got 3 sutures at 4 o'clock, at 8 o'clock, 4 o'clock and 6 o'clock. Now we'll be getting the graft in. I generally put 3 sutures there and 3 on the distal tip, and then take 1 or 2 laterally with the help of the Killian's forceps. Forceps, vascular forceps, please. Yeah. Yeah. Yes. Okay, fine. Can I have the needle holder again? Yes. Idea is to take the sutures through the graft and then gently parachute it inside. Hold this. This is on the inner part of the graft. This is on the inner part of the urethra. So this will go on the inner side of the forceps to me. Yeah, forceps. Hold this. Can I have the same? Keep it there. Keep it there. Let it. Can I have the forceps here? The same mosquito that you had given me earlier. Mosquito artery forceps. Yes. Can you get me the next one? So see whether it's moving easily or not. Yes, it is. Out in and in out. Yes. Yeah, 3 stitches there, 3 distally, and then I'll take 1 or 2 on the lateral aspects after fixing it. Fine. Hold this. Tips. Parachute all three. The graph moves closer to its destination. Can you just keep this away? Keep this things away like this, gently, so that it should allow for the movement of this graft. See, I am giving some amount of traction, but it's holding, which indicates that the inner side is robust. So, don't pull that, just relax it a little bit. Forceps, please. Yes. Hold this. Okay. You have to be very careful while taking these bites.
So for this ventral inlay,
Yeah.
Dr. Naik,
Yeah.
how much width of the graft you want to take?
Actually, this is little bit less, but still I would prefer with a good amount of traction and incision, you still would get about 1 centimeter space. So if you have 1 centimeter or 1.5 centimeter, I guess that is enough.
Whole idea is to have a
Wide graft.
how much you want to dilate the urethra?
See, you should have 16 French to 18 French urethra.
18
Even
only.
the normal thing is only 6 mm, right? So 6 mm is the normal diameter.
Okay.
Yeah, so that is 18 French. So that is what we should aim for. So if you are buttressing with something that is 1 centimeter, that itself is will give you 30 French. See, this is also sliding easily. The moment it slides easily, you know that your take is robust, and also that there is no twisting of the sutures.
These are the lateral stitches.
These are the proximal sutures, almost close to the apex, near the bladder neck, just stopped short of bladder neck. Interrupted for the proximal ones.
The first few stitches are
Yes.
interrupted and then you go continuous.
No need for continuous. I put all interrupted.
Okay.
Here.
In a ventral onlay, Prashant, do we do a quilting, a proper quilting?
No, I do not, because it is not easy to do that, and studies have shown that you do not need to do that. If you have 3 proximally, 3 distally, and get some lateral sutures in, I think that does the trick, and then putting a catheter of say 16 or 18 French, that keeps it in place.
Would you leave a vaginal pack?
I generally don't.
Are you worried about a hematoma which could form in this small segment?
That catheter which is there, that takes care of that. That
Okay.
keeps it pressed. We
Okay.
just our idea is to keep the graft in place until the mucosa regenerates.
Yeah.
There has to be mucosal invagination. Graft only is acting as a scaffold. for that.
Scaffold. The early scaffold, the first 5-7 days.
Exactly.
Yeah.
So that is what we need. How long do you keep the graft, Dr. Sanjay?
Pardon?
I said this. How long do you keep the catheter inside?
I've kept catheter between 12 to 14 days,
Okay.
depending on my on-table comfort.
Okay.
But authorities talk about catheter being kept for 14 days. Is there any change in practice?
No, of late, I think because this mucosal regeneration, there has been some studies in tissue grafting,
Yeah.
and they said that the tissue grafting takes as long as a month.
Okay.
So
okay.
I think we used to keep it for a month some time back.
Yes.
Then we is reduced it. Now
3 weeks?
yes, 3
3
weeks.
weeks. 3 weeks
to
is
a month.
what I hear ideal from some of my colleagues around.
Yes.
Tomorrow, 15th day, I'm removing a catheter in Mumbai. So
Okay.
got used to a little bit of playing safe.
Can I have some jelly, please?
Great.
Yeah. That's it. Now you have the mucosa which is anchored proximally. I will do the distal anchoring now, and after that I'll take in between 1 or 2 lateral sutures.
Okay. Okay.
Can
seems,
I have the
seems good.
suture? Now whatever cut suture is there, you give me. ठीक ଅଛି ସେଇଥିରେ ଦିଅ. No, not. I think that light is coming.
Is the speculum the apt size that you would like to?
No, I would like to have a little bit longer speculum would have been better.
Longer and thinner kind of thing
Yes,
around?
longer and
Yes,
thinner.
longer and thinner. I wish Arvind could tell us if we have that kind of speculum in India. And the
Arvind
blade.
was very picky about his speculum. I
Yes.
think he would be the right person to talk about it. Is he
Yes, I
around?
think I'm just searching him around. Got that in Germany. The other thing was the blade. For the inlay kind of techniques,
Can
the
I have
blade
one
we
too?
need to use is the iris blade.
Yeah.
The blade that ophthalmologists use, we need to
Yes.
borrow from them.
Yes.
But then you're doing a fine cut and you're doing the cut that is only mucosal.
Just can
You're not
you
doing
remove
what I did, a complete urethral, incision around here. So that could be great for the technique that
Yes.
Prashant is showing, and great for technique which dorsally that Arvind showed. So that's for a lot of our colleague audience looking at iris blade as a fine blade for the incision and then separating them. This is coming out very well. This is coming out wonderful.
it? You just have to be a little bit patient in getting those initial proximal.
Yes, yes.
Just
I
right.
decided to slow down when I had a friable injury there. So,
Yes.
so it's nice to slow down and probably look at
Yes.
best bites at the angle. Yeah, well said. Dr. Prashant, we have a question from Jaipur.
Yes. Sir.
Somebody wants to know the ventral onlay.
Yes. Ventral onlay, but this is inlay.
Inlay, yeah.
Yeah. Right.
Why has this ventral technique not been so popularized? Male, female. You are sitting on at the driver's seat right now. Is it too
Yes.
difficult technique compared to the first 2 cases we did, or it's more easier? How does it look like for a new starter?
No, you can do it. Only thing is you are working at a depth inside.
Yeah.
And it takes a little bit of effort to get those sutures right. But I have had no difficulty in going right up to the bladder neck also. So
Yeah.
strictures that are longer also.
True.
If you can cut it and get it separate, then you can go right up to the bladder neck also.
Yeah, I can see a wonderful demonstration actually. Both the edges.
You can see the edges here.
You can see the edges so well.
Yes, and you can see mucosal edge, and you can see the.
Yeah, the glare is so minimal, and I can see both the edges. You can see the.
I think the oozing a little bit less here.
Yes, it looks good. Looks good. Looks very good. You got top class, colleagues assisting us.
Of course,
Yeah.
of course. We have got wonderful colleagues here. So it has been a
They're all looking.
working here.
Yes,
really.
it's actually. Thank you, Dr. Debadarshi, for having organized such a situation where colleagues who have not assisted us have taken, rotation in terms and assisted Dr. Aravind and myself. And no, wonderful kind of thing. I can see that. Did you take a class beforehand for the staff to know what are we going to do? And this is because this is a novel completely for the institute. And let me confess that the entire staff out here in both the parallel OTs running together have actually been in sync with what are we doing in terms of suture material, in terms of positioning, in terms of the nurses knowing when to and how much traction to pull around. Quite happy about that.
I think they're all very good.
They're all very good actually.
They are all amazing. Yes.
And entire organization, I must really thank the organizers. It was a great experience, and we are really thankful that the organizers
Can I have
did invite us.
cut?
And it was a wonderful experience. I'm sure everyone has enjoyed. Even we have learned so much from this. And I once again thank the staff who did a great job, and of course the faculty of Department of Urology, SUM Hospital. Thank you so much.
Very well done. Unfortunately, we have been looking at reconstruction, and therefore time is always a constraint.
Yes, time is always a constraint.
Always a constraint, and
I think if we can start another one, we can go.
We
that
are
side,
looking
yes.
at the last case going live at some point, which could be on request a vestibular flap
Yeah, I think that would be interesting.
or
to
a
see.
vaginal flap urethroplasty.
Yes.
A little elderly woman who has a refractory stricture up there.
No, you can go ahead. And 10 to 15 minutes.
So next case could be a 70 years old lady with refractory stricture, and we look forward to timelines, but we'd go though off air.
Preoperative person related to that aged lady in a estrogen paper.
It would be nice to estrogenize her for a while, because we're looking at obviously we have a capacious vagina, so that is one good news in terms of being able to take a liberal flap. I do a flap of either the Orandi kind, long segment, or the vestibular flap to pull out, dissect a distal urethra, excise it, and then put a vestibular flap. Any of the two techniques. The estrogenization would have been a good idea, but to prefer that in a younger woman, yes, that's ideal. So that's why a 70 years old lady, refractory distal stricture, looking forward to a vestibular flap urethra. We'll just start it on the other side. I hope we can go online for a short while. But that's good, because capacious vagina won't be sexually active.
Specifically, muscularity and all that will be a little bit of
True.
increase with hormonal applications.
Absolutely. So I normally would look at estrogenizing her a little bit locally for a while. It just improves, like in the VVF repairs we do.
Ideal time period we should wait for
6 weeks.
at least.
6 weeks of estrogenization would be good for any kind of these repairs. Either it could be those VVF in that group of women, or looking into the situation we are going to handle next. And they won't be sexually active. So the issue about sensitivity, discomfort, pain does not come into play when we look at her passing urine well and not having high residues and recurrent UTIs. One of the pictures we showed, recurrent UTI being a second common presentation apart from obstructive voiding. So that's one thing which we look into. So that's one. Prashant, anything specific on instrumentation in your technique that you're demonstrating?
No,
for
what I did was that traditionally what we do even in a male urethral stricture, when you're taking the proximal bites, as I showed my technique of going in, dipping in first and then turning it. So that is what is the concern while taking those deep sutures here.
Yeah.
So that helps. First, just wedge it where you want to take the bite, and then turn the needle, which is easier, and then just drive it inside rather than trying to go at an awkward angle and trying to get it inside.
Yes.
What is your advice regarding post-operative follow-up and all? Any specific difference for this?
No, nothing. I just need to have a catheter in place and she needs to come back. I generally keep it for between 3 to 4 weeks. And after that I remove the catheter. I don't have any long-term results, but whatever patients in past 6 months, they have been doing well. So,
wash karuchu. The vestibular flap chesta kare.
yes. Can I have some jelly? हाँ पिक्चर तो भलो है हाँ yes yes हाँ yeah yes it's ready we can score them. I'll just want to take 1 or 2 lateral bites. Can I have the light here? You can see the graft nicely sitting there. Yeah, camera vision will be good really. See the ventrally we can see the graft nicely sitting there. Yeah. Yes, projection is cannot use. Can we get an endo camera? Just get it ready. Just get it ready. We'll yeah get a pediatric scope. Hold this. Can I have the switcher please? Bus. AC the 24. It's difficult to do that because I don't think it's possible to do that. No, I think it's not possible. Because lateral is not necessary. Yeah. I am done. I just need to put a catheter in. If you can get a camera, I think Dr. Samir wanted to see. This, are you ready that side? Okay. Achha, I'm coming. Just to see that. Just remember. Wait, correct.
What a second.
It stuck nice. I felt easier. Taking. Thank you. Dorsal messi spongitis to the dorsal rachi. Sub clitoris and everything. हुए नहीं. Vagina is intact. Vagina is intact. Vagina intact. Boogie, हाँ रखी दिला हवा. Are you ready? हाँ हाँ. हाँ.
So this is the bladder neck, and this is the graft.
See, the graft is there. This is the graft.
This is the graft
starting from here.
Yes.
And
Nice.
up to the area.
Nice,
See,
yes.
now beyond this area,
yeah.
this is normal mucosa. So you don't need. So this is the bladder neck.
Correct.
This is about ½ centimeter of normal mucosa. Then where the abnormal mucosa starts, so graft starts from there. And so the graft will be in place.
Very nicely demonstrated. Thank you very much, Dr. Nayak.
You can close it.
So now we have come to the end of the third case. There is a slight presentation ceremony to conclude our session.
Give me a catheter.
Our chief coordinator, Dr. S.N. Panda, will be giving the mementos to the operating faculties. 80, 80.
Fine. ಅಷ್ಟೇ ಅಷ್ಟೇ अब रेडी खोली दबो इस थिंग्स हाँ फ्यूचर ओके ठीक है এটা ইয়ে লাগিয়েছি দেখে
So I am really thankful to all the audiences who have given us the opportunity to see how this small urethral length surgery can be so fantastic. Never been explored anytime, ever, anywhere. And we did the course, and our operating faculties, they shown us different kind of things. One of them was dorsal inlay, one was dorsal onlay, and the third one was ventral inlay. Due to shortage of time, we are not able to show you any type of flap urethroplasty. We'll be continuing with the case, but we'll be signing off right now at 6 o'clock. Before that, I would like to have some token of love and appreciation from our department, IMS SUM Hospital, Bhubaneswar, to the faculties who have operated and demonstrated so nicely. Our coordinator, chief coordinator, Dr. S.N. Panda will be giving off the mementos to our operating faculties. Please, sir. Dr. S.N. Panda is giving off the mementos to Dr. Arvind Panda from CMC Velo, Professor of Department of Urology. Dr. Sanjay Pandey from Kokilaben Dhirubhai Ambani Hospital, Mumbai. Thank you so much. Dr. Prasan Nayak, Associate Professor, IMS, AIAMS, Bhubaneswar. So they are the operating faculties for today. And thanks a lot. Thank you once again for viewing us. And we'll be signing off right now. Thanks a lot. Good day.
Good show.